Welcome all to the fourth meeting of the Joint Interim Standing Committee on Health and Human Services. First of all, I'd like to take a moment to thank all of the staff who came in early this morning. It is raining cats and dogs in Reno, and it is slow going out there. So thank you so much for being here early enough to get us started this morning. I apologize for my tardiness. It took me a little longer to get through the valley than I anticipated. We are going to go ahead and call roll first. For those members attending virtually, would you please turn on your cameras and respond when you hear your name? Ms. King, please call the roll.
Senator Doñate?
Here.
Senator Hardy?
Here.
Senator Harris?
Here.
Assemblywoman Gorelo?
Here.
Assemblyman Hafen?
Here.
Assemblyman Orentlicker?
Here.
Assemblywoman Titus?
Here.
Chair Peters?
And I am here. I believe that makes all of us present today. I'm going to go ahead and make a couple of housekeeping announcements. We've been doing this for a little while, but just in case you haven't had another committee this month, we're going to go through some of this. First, I'd like to remind everyone to please silence all of your electronic devices, especially cell phones and laptops during the meeting. Everyone is using laptops to keep track of notes and keep track of their personal all of the stuff we use personally to ensure that we're paying attention and taking all of our required notes for the meeting, so please excuse us for looking down at that. For members joining online, please mute your microphones when you are not speaking, but leave your camera on so we can maintain that quorum and know when you are present. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda item under which you will present, or if I direct any questions to you. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance. Any links or information that you would like to share during your presentation should be stated verbally on the record, and that also pertains to committee members. Agenda items may be taken in a different order than listed. 2 or more agenda items may be combined for consideration. An item may be removed from the agenda, and discussion of an item on this agenda may be delayed at any time. The committee members' materials can be found on, the committee's meeting materials can be found on the Nevada Legislature's website. You can also sign up for electronic notifications related to any activities on the committee's website. If you wish to testify in person, please sign in at the table by the door in either building and leave a business card. If you do not testify, you may also want to sign in so there's a record of who is interested in a particular topic, and in the event that the committee needs to contact you later. When testifying in person, please turn the microphone on to speak and off to listen, because we have others listening to and viewing the meeting in Las Vegas and online. We will have a public comment period at the beginning and end of the meeting. Public comment is limited to 3 minutes per speaker to ensure everyone has an opportunity to talk. In addition to testifying in person, members of the public may provide public comment in 4 different ways, all of which are listed on the agenda. You can provide public comment by calling 669-900-6833 and entering meeting ID number 818-1495-9426, and then pressing the pound sign. When prompted for a participant ID, please press pound again. You can also provide written public comment by emailing comments to the committee email address, or mailing or faxing written comment to the research division. You can find the phone and fax numbers, email addresses, and mailing addresses on the agenda. With that, we will go ahead and move on to public comment. As stated before, public comment will be limited to 3 minutes per speaker. Staff will time each speaker during public comment to ensure everyone has a fair opportunity to speak. We also ask that you do not repeat what a previous commenter has stated. An additional opportunity to make public comment will be available at the end of the meeting. We will start with public comment from those in the physical locations and then move to public comment from anyone who has called in. Is there anyone in Carson City who would like to provide public comment this morning? Not seeing anyone come up to the table, we'll go ahead and move it to Las Vegas. Is there anyone in Las Vegas who would like to provide public comment at this time? I don't believe anybody is moving. Thank you. Broadcast and production services will interact with those making public comment to facilitate participation in the meeting. BPS, can you add the first color to the public comment line?
Thank you, Chair. To give public comment, please press raise hand in your Zoom window or *9 on your phone to take your place in the queue. Chair, there are no colors for public comment at this time.
Thank you so much. There will be another opportunity at the end of the meeting for public comment if there are folks who would like to do that during the meeting and would like to call in at that time. We're going to go ahead and move on to agenda item 3, approval of the minutes for the meeting on February 17th, 2022. Members of the committee, are there any questions regarding the minutes? I will entertain a motion to approve the minutes of the committee meeting on February 17th, 2022.
Move to approve.
There's Dr. Titus has made a motion to approve the minutes. Is there a second?
Second.
I believe that was Senator Harris.
Yes, Chair. I'll second that motion.
Thank you. Thank you so much. Are there any comments or discussion on the motion before we vote? Wave me down. All right. All in favor, say aye.
Aye.
You can raise your hand if you're on the screen. Okay. Any opposed? Motion carries with all present. Thank you so much. Next, we're going to move on to agenda item 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B.225. Eric Robbins, our Principal Deputy Legislative Counsel, will go ahead and walk us through these regulations.
Hello, Eric Robbins from LCB Legal. So the committee has 4 regulations that they're reviewing today, and as a reminder, the committee doesn't formally approve or reject the regulations, but this is an opportunity for members of the committee to ask questions and provide feedback to the agencies concerning their regulations. The 4 regulations we have today are LCB file number R007-21 of the State Board of Pharmacy, R062-21 of the State Board of Health, R064-21 of the Speech Language Pathology, Audiology, and Hearing Aid Dispensing Board, and R028-22 of the Board of Medical Examiners. And we have representatives of the State Board of Pharmacy, State Board of Health, and the Speech Language Pathology Board available virtually. And we have a representative of the Board of Medical Examiners here with us in Carson City to answer any questions that members of the committee may have.
Thank you so much, Mr. Robbins. I just want to remind the committee that this is informational only. Staff informed you about the status in the regulatory process of the regulations that we are now considering, and I believe none of them have been approved by the agencies that are bringing these regulations, so there are still opportunities for public input at this time. If you have a greater interest in participating in the development of these regulations, the process can be found on the LCB website, or you can reach out to staff for additional assistance. Committee review is an important process for follow-up on bills that have passed in the last couple of sessions, but we will not be taking any action on these items today. I believe Dr. Titus has a couple of questions on these regulations. Please go ahead.
So I'd like to just start in order and start with the R007-21 State Board of Pharmacy regulations. Is there anybody from the board?
Yes,
Yeah.
I'm here, Dave. Yes, Dave Weiss from the Board of Pharmacy, the executive. I get my camera going. Good morning to you.
Thank you, Mr. Weiss. Go ahead, Dr. Tice.
Great, thank you. So I just need some clarification and maybe a reason why the oncology group practice is being identified as needing a kind of specialty line. There are many group practices out there. In my office previously, we'd have medicines that were locked up, considered, dangerous medications, narcotics, et cetera. And there would be several people in the office. And so we didn't, in my mind, and I think we need clarification, or I do anyway, need a separate designation as this oncology group practice. So could you just explain maybe briefly what prompted this to be identified as needing a special clarification?
Yes, ma'am. Dave Weiss for the record. So practitioners do two things. They administer, and then they also are allowed to dispense, similar to a pharmacy or a pharmacist. We're not talking about the administration. So all the doctors, like to your point, if they have a shared inventory of drugs, that's not what we're talking about today. We're just talking about if they're going to actually dispense them, put a label on it, counsel the patient, and give the patient a bottle of medicine to take home. They have to get a separate license to do that from the state, dispensing license. And currently the law, because they're all individuals, require that inventory to be separate. The oncologists petitioned the board, and we're in the middle of the process of hopefully approving this, where their drugs are very expensive. If they all had to have a $10,000 bottle of drug, then they have to have $100,000. So they were hoping that the board will allow them to, for just the dispensing, be able to put those together. So we're not talking about your typical practice. This is a dispensing practitioner.
So to be clear then, and thank you for that, this was requested by the oncology groups?
It was. I expected other groups with other expensive drugs might request it down the road, but the oncologists requested it. The board's trying to work through the regulatory process. Obviously, LegCom will approve it if they choose to approve it.
Great, thank you. Thank you, Madam Chair, for the question.
Thank you so much. I believe you have a question on the next regulation as well. I'm sorry. Are there any other questions on this? We're just going to go through them one at a time. So does anybody else have, members of the committee have questions on Regulation R007-21 for the State Board of Pharmacy? I do not see any. Thank you so much, Mr. Weiss. We will go ahead and move on to the next regulation, R026-21. Is there a representative from the State Board of Health available? I believe.
Hi, my name is Letitia Metherell, the Division of Public and Behavioral Health. And I also have with me April Clyde, who is a certified nurse midwife and the owner-operator of our only licensed freestanding birth center in Nevada, to help answer questions as well.
Thank you so much for being here. Dr. Titus, please go ahead with your question.
Thank you, Madam Chair, and I know that there are others who have questions. I'll keep mine brief. And on the fee structure, I was just curious as to how, and again, there's other, on the policy itself will be questions, I'm sure, but on the fee structure, how did you arrive at that particular fee? When I looked at the litany, the laundry list of fees that you have in there, and I just needed some clarification on how you established what you did.
You know, that was our existing fee for our obstetric centers, so I really just left it the way it is. I don't know how it was originally established, but it was our existing regulatory fee, and so we just left it the same.
All right, thank you, Madam Chair, and then I'll have, I may have other questions, but obviously I want everybody to have an opportunity. Thank you.
Thank you so much. Are there other members of the committee with questions? I see Senator Hardy. Please go ahead.
Thank you, Madam Chair. On the freestanding birthing center, I look at all of the things that deal with everything being built. I'm concerned about, and I guess I only see oxygen being able to be used on the newborn. Is there some other allowance made for making sure that the newborn is appropriately treated?
Yes, Senator. Assembly Bill 287 required us to align our regulations with one of the standards listed. One of those standards was the Commission for the Accreditation of Birth Centers. So we did adopt that by reference. It's the indicators of compliance with standards for birth centers. It is a very extensive coverage of what is required in a freestanding birth center. So I'm happy to provide that document to the committee. It's over 200 pages, and it really outlines all of the requirements. So you don't see those actually in the regulations because they were adopted by reference.
So they're already adopted?
Oh, I'm sorry. Pardon me. No, they are not adopted. They were put in the proposed regulations to be adopted by reference if the Board of Health does happen to adopt them during the Board of Health meeting, which has not occurred yet. It is scheduled to occur in June.
So what section is that referenced in?
Let me find it here for you.
And just as a reminder to speakers, would you please state your name before speaking for our records so that we can keep those minutes clean?
Yes, Letitia Mather for the record. Section 6 talks to being accredited by the commission for accreditation. And then let me find the section that talks about adopting it by reference.
Eric Robbins, LCB Legal, for the record. I believe it's section 12.
Thank you.
So if we could have that information available to us before it gets to the Legislative Commission, I'd appreciate it.
Yes, we'll be happy to provide you a copy.
Thank you.
I'm not sure. This is April Clyde. I'm a nurse practitioner and owner and founder of Serenity Birth Center. I'd just like to speak a little bit on this. So every attendee at the birth center is required, so it's a nurse practitioner and an RN that attend every birth. We're required to be neonatal resuscitation trained. We're required to carry all of the medication to take us all of the way through the protocol of neonatal resuscitation, including epinephrine, and that's all stocked and carried at the birth center.
Do you have the ability to do umbilical cannulizations?
Absolutely. Mm-hmm.
Appreciate it. Thank you. Thank you, Madam Chair.
Thank you so much for the questions. And just as a follow-up, would you mind sending that information to staff, and staff will distribute it to the committee so we all have access to that. And we can also add that to the meeting webpage for the public's information. Are there any other questions that folks would like to ask before I come back around to Dr. Titus? Oh, Dr. Titus says that she is okay. I don't see anybody else. Assemblyman Hafen, I thought I saw your hand pop up, but you guys are itty little bitty in my screen, so. Okay, I think we're good to go. Thank you so much for being here. We look forward to seeing how these regulations are heard by the board. We're going to go ahead and move on to the next set of regulations for questions. That is R064-21 from the Speech Language Pathology, Audiology, and Hearing Aid Dispensing Board. Do we have someone on Zoom from that board, I believe? Or maybe in person in Las Vegas? Oh, here we go, it looks like. Hello, please introduce yourself.
Morning. Good morning, Chair and members of the committee. My name is Jennifer Pierce. For the record, I'm the Executive Director of the Speech Language Pathology, Audiology, and Hearing Aid Dispensing Board.
Thank you so much for being here this morning. Well, I know Dr. Titus has a question related to these regulations, so we'll start with her, and I will go to other members as they let me know.
So thank you, Madam Chair, and thank you for being here today. So I know how in this particular regulation that it was started through our last session when we passed a bill regarding professional licensure, and we cut back across the board from 15 hours to 10 hours, and that this board is now just following what the direction was from the legislative process. My question for you is, are you going to allow, or are they, how do they get this this hour of CME or CEUs, or however you define it in the speech path world? Will you allow them to sign on to a generalized education on cultural competency, and is it available to everybody? Are we able to rev this up so that these professional groups, specifically speech path, will have access to this education?
Sure. So our continuing education rules sort of will blanketly be, will blanket accept certain activities from different affiliated organizations like the American Academy of Audiology, the American Speech Language Hearing Association, et cetera. And then we also allow for any courses directly related to the profession, done through a university, school district, et cetera. And I think we're finding that this is, so the recommendation to include the cultural diversity and cultural competency hours came directly from ASHA, which is the accrediting body for most of our SLPs and can also be for audiologists, although we don't have quite as many. And they are changing their regulations. They currently require 30 hours in a 3-year period. And their new requirement for continuing certification will be 1 hour of ethics and 2 hours of continuing or cultural competency. There are quite a few courses online that people take, and so we're comfortable believing that there are lots of opportunities and our rules are flexible enough at this point that somebody can find related content to the requirement for cultural diversity training.
Follow up, Madam Chair? So just clarification then, because as a physician, we have to do that also. So if you'll have your own, the audiologist or speech path will have their own classes on cultural competency or related things, or will you're not, I'm hearing that you're going to be developing something or something's already developed as opposed to having a healthcare class, so to speak, that covers it. Is there some uniqueness for the speech path that would need to be included in the ones you're developing?
No. And for the record, Jennifer Pierce from the Audiology Speech Pathology Board, we are not developing anything specifically, but our current requirements around continuing education are fairly broad. So somebody could go find training in cultural diversity that would likely meet the requirement for us. And it would not need to be specific to speech language pathology or audiology. But there are Audiology Online, for example, is an online training database that many of our practitioners use for quite a lot of their training. And there are opportunities to do ethics and cultural competency CEs through there.
Great,
so,
thank you.
It does not have to be specific.
I just think it's important that it's available, that folks can be able to have access to it, and so that it's easy for them to reach out and get this education, because I think it's important, but I just want to make sure there's no barriers to it. Thank you. Thank you, Madam Chair.
Thank you.
Thank you so much. Thank you for being here today for that question. Are there any other questions from the committee on this set of regulations? I'm not seeing anybody wave me down. Thank you so much for being here. We will go ahead and move on to our next set of regulations, R028-22 of the Board of Medical Examiners. And I believe we had someone in person, thank you, available for our questions. I know that Dr. Titus has a question, but please let me know if you have a question, other committee members. Please go ahead.
Thank you, Madam Chair. And again, do we have somebody from, oh, we do, right at the table. Thank you. So looking through this, I'm concerned. We already have a limited amount of healthcare providers getting people to work in doctors' offices, nurse practitioners' office, and all providers' offices. There's not enough of us. And so now having requirement of a patient attendant to be there in addition to everything else we have to have in the office. I just have some concerns about that. Having practiced many years, way many years, and I just know that sometimes you just have to go in and you have to examine a patient, you have to take care of them, and not always having that extra body to be there. So I'm wondering how this is going to be enforced, how we're going to, and I understand why. I mean, I understand for patients, I guess you said patient protection, you have to have the patient attendant, but it just seems like this extra person in the room, and I just have concerns.
Okay. Sarah Bradley, Deputy Executive Director for the record of the Nevada State Board of Medical Examiners. Well, the regulation as drafted does have a exception for emergency care, so in an emergency situation. It's also limited, it's not in every patient encounter, it's patient encounters where there's a visual or physical inspection of genitalia, rectum, or breast of a patient, or other kinds of basically more invasive procedures in those areas of the body. So it's not every single visit. It's our understanding, and there's been some conversation, because as you can imagine, we receive complaints about this a lot. And so I mean, the intent is really to require that this person be in the room when these things occur and that their name is noted in the record, and that way it's clear who is there. We got some of this language from the Federation of State Medical Boards, some guiding language. And I guess I would just say, I mean, frankly, it's an issue that we're struggling with how to best protect the public. And we have some situations where when we have a complaint come in, we have 2 physician members and a public member that review, our investigative complaints. And, they will say, I think it's standard. Yeah, you should always have someone present. And so that's what they're saying. And so my thought and our concern is, well, let's codify that then in the regulation. We don't enforce it currently. We recommend it frequently when we do get complaints regarding unwanted touch and improper things. So we often recommend it. We haven't been requiring it unless it's a disciplinary case, and sometimes we then do it. But what we've been hearing anyway, or at least I have as a staff member for 2.5 years at the board, is that the board physicians are saying this is standard. You should have someone present when you're doing this. Now, we have not done a workshop or a public hearing on it yet, and I'm, as you are, expecting to get a lot of comment. This person doesn't obviously have to be a physician. I would say they're more like an MA, potentially position, but I agree with you. We know there's work staff shortages, so I don't know what comments we're going to get. The intent is not to make things harder. The intent is to, I think, put into the law what at least I have heard from multiple physicians on the board is already the standard of practice when these things are done.
So thank you for that follow-up, Madam Chair. So I was a member of the Board of Medical Examiners and in the 90s, late 90s, and again, I was part of the investigative committee, and we look at charts and complaints, et cetera. And in my own practice, again, you would have that standard of care where if it was going to be an exam, my assistant would be in the room with me. And other times, I wouldn't have one. And so especially, say, I'm doing a breast exam on a female, I wouldn't necessarily have that my assistant in the room. He or she could be doing other things. And so, I mean, I just think that because it was the provider's discretion, and again, the standard of care would be to have somebody there in certain situations. If the provider, just to, like you said, to codify this has me a little bit concerned, and I'll be very curious to see what the comments are when you do go out and have this public hearings on this as providers in general across the board in practices, especially in rural areas where we just don't, sometimes you're the only person in the little clinic in Austin, and now to have that second person who's trying to answer the phone and now they have to be in the room. I just am really concerned, and there would be certainly times where I felt I would go out and get my MA or the nurse to be in that room with me, but it was at my discretion as a provider. And so to put this into to codify this, as you use the term, I just have some concerns about it, but certainly I understand it's just a proposed regulation. You're going to be doing hearings on this and what's best. But again, I agree, it's standard of care when possible, but gosh, sometimes that just doesn't happen. So to propose disciplinary issues if somebody doesn't do that, I just think it's setting healthcare providers up. So, and I understand, protecting patients, that's what I've done my whole life. So that's where my concern is. Thank you.
Sarah Bradley, Deputy Executive Director for the board. Just to respond quickly, I mean, I think we aren't going to be, just to clarify, I don't anticipate that we're going to be going out and looking at charts in offices and inspecting for this. Really, most likely, it's going to be a tool when we get a complaint. We then look in the patient record and say, well, who was the patient attendant? And when there wasn't a patient attendant, then maybe that's a way to kind of help curb some of this inappropriate touching, inappropriate action. So, our intent is, I mean, we don't have the resources to inspect every office and look at all the records, but I think from that perspective, because a lot of times now, as you can imagine, we have he said, she said situations, or she said, or, whatever it might be. And, we can't always take action. We don't want people to ever be hurt. And so this way, at least, they're required to put something in the record. If we get a complaint, we can at least see who was in the record. Maybe interview that person, talk to that person, and they can say, oh, no, there's nothing here. So that at least gives us another investigative tool. And then if someone is routinely not following this reg, I think that gives us a disciplinary tool that, again, maybe can help stop the bad people from doing the bad things. Yeah.
Thank you so much. And I just want to make a couple of comments that I think that this is a really interesting topic to take on. The idea of consent has been something we've talked about in this legislative body, at least the 2 terms that I've served. And we have had a hard time figuring out what that means for everybody, right? And then this brings up the idea of patient consent to another observer in the room. And what does that mean for the patient? And then also patients' knowledge of their rights and their ability to understand or their knowledge base of understanding what their rights are, to ask for someone in the room to ensure that things are fine. And then also I'm thinking about when I go in for my well exam and I ask, it's maybe not part of my wellness exam, but I ask to have a breast exam done. And does that mean that I then take up more time of that doctor's by having them go out and ask somebody to come in at those times? So I think this is a really interesting discussion, and I imagine you will get a lot of comment, and I hope that you do. And I think that the conversation around what consent means in all places of our lives is really an important piece for us to take very seriously in statute and regulation. So are there any other questions from the committee? Oh, I see Doc Hardy's hand is raised in the committee room. Is there anybody who would like to ask a question so I can get you on my list before I let Doc Hardy go ahead, Dr. Hardy go ahead with his? Okay, go ahead, Dr. Hardy.
Thank you, Madam Chair. I appreciate it. So one of the things that sometimes we forget is this is the kind of thing that protects the doctor as much as it does the patient. So if the doctor, let's say there was a complaint made and the doctor says, no, I had somebody in the room with me. That protects the doctor every bit as much as it protects the patient. Now, if the doctor happens to be male and the female is the patient, Dr. Titus, she probably has an advantage over me when she's doing an exam or over any male physician. So has there been any differentiation in the federal board of or any other place that looks at the 1% versus 99% or whatever it is complaints? Has that come up in these discussions at all, as far as gender to gender or gender not to gender?
Sarah Bradley, Deputy Executive Director for the Nevada State Board of Medical Examiners, for the record. We've discussed it. The board discussed it even. So this regulation, so we normally, as staff, come up with some potential ideas based on things that we're seeing and or things that the board has requested. So at the March board meeting, the board did review this and talk about it. And I expected them to maybe bring this topic up, but they seemed comfortable with requiring it regardless of gender. At least that was the sense I got at the meeting, and a couple board members when they said that to me. I will tell you from the complaint perspective, I've seen most of the complaints are female patients complaining about an improper touch by a male physician. However, we've had male and male complaints. I'm not aware of female and female complaints. And so just given, the changing landscape and trying to make sure everyone's accommodated, I guess our thought was, an improper action can happen from anyone. And so if we're going to do this, and so that's at least where we started with this. You're right. And I mean, as a female patient myself, I understand the difference between going to, providers of, my same gender versus male. So it's an interesting topic. I'm expecting there will be a lot of conversation. And then also, too, just to address something that the chair mentioned, we were trying to be cognizant, too, of having another person in the room because this is sort of a sensitive situation. And so we do have it in there that, the patient, and we want them to be informed of this, the patient can say, no, I don't want to, I'm fine. I don't want to, another person in there. Let's just be a little more private, because I do think that's up to them. But I guess our thought was, at least for now, we're proposing a third party be there. I know male physicians, at least in my personal experience, always do that. And then there are some that don't, and I think those are the ones that we get the most complaints about, I guess. And so we're trying to just sort of make sure that everybody knows this should be done rather than just recommending it. Because when we recommend it, we're saying if you do this, you probably won't get future complaints, but we're not really addressing whether or not something bad did occur. It's hard because, again, we're also saying in here that the chaperone, the patient attendant, they have to report things to the board directly. And so they're kind of there more for the patient, which I think is good, and that's part of our intent. Anyway, it's an interesting role because we want them to also know in here, what the scope of the encounter should be. What should this exam entail, right? Because how would you know something improper is going on if you don't know what the exam should be? So we're trying to address everything we can. And again, I'm looking forward. I've not scheduled yet the workshop or public hearing. We actually just got this draft back, I want to say within the last 2 weeks, and we submitted it in March. So it was a very fast turnaround. We haven't had time to schedule, but our plan is to definitely take whatever feedback we get and try to refine and have what we can to protect the public the best we can. I mean, that's our goal.
So if I may, I guess this would be a confession now. I don't remember this. First of all, this bill started out as a pelvic exam bill. And I don't remember, as a family physician, ever getting somebody in the room for me to do a rectal exam, checking for a prostate or getting a guaiac stool. I mean, I don't remember ever doing that. So what you just did with your testimony is you opened that up for male physicians to always have an attendant there, if I understood you right, whenever the male physician does a rectal exam on another male. Is that what I heard?
Yes, and that's in the language in the proposed draft. Sarah Bradley, Deputy Executive Director for the record. Yeah, it says any of those exams. Yeah.
Was that in the bill?
Sarah Bradley, Deputy Executive Director, this is not regarding a bill. This is a regulation that the board is bringing forth on its own, given complaints and issues that we see. So this is not related to a bill. I know what you're talking about. There was a bill regarding pelvic exams and other exams in emergency situations, but that did not cause us to bring this. We're bringing this independently to try to address concerns that we see.
Thank you, Senator Hart.
So I'm not done. Thank you.
Okay, I'm gonna give a little leeway, but we do have an extensive agenda to get to. So, last question, please.
So this is going to be quote unquote an investigation. If the complaint goes to the board that somebody did something that I don't think was right, it goes to the board. The board says, yes, the record shows that somebody was there with the doctor when the doctor did whatever she was supposed to do. Does that complaint now qualify for an investigation, like all the complaints heretofore have happened recently? So now the doctor has to say she was investigated on all of the national database things.
Sarah Bradley, Deputy Executive Director for the Nevada State Board of Examiners, for the record. This does not change the board's investigative process. So when a complaint is received, it's reviewed. If it's within the board's jurisdiction, it's opened as an investigation, and an allegation letter will be sent to the physician. And that's generally when we ask for the records, and then those records would be showing us the patient attendant's name and again, it gives us a witness potentially to talk to. It helps us in our investigation, and it helps the physician or the physician assistant in the investigation as well. So no, the intent is not to change the process for investigations at all with this regulation. It's really just to kind of, I think, aid investigations regarding an improper touch when that's alleged.
So what's the timeline that you have of clearing investigations now?
Sarah Bradley, Deputy Executive Director. Could you repeat that question? I'm sorry.
So you have a board that gets the record, knows that somebody was there, everything was done right, an investigation was opened, and how long does it take to clear that investigation so the doctor doesn't have to say on his database that I'm still under investigation?
Okay. Generally, so it depends, because when the complaint is received, Sarah Bradley, sorry, Deputy Executive Director for the record, but when the complaint is received, the licensee gets a letter saying that there's been an allegation made, and they're given 30 days to respond and provide records. And so there's some time for them to respond. Then there's time for board staff to review, and then all complaints are put on an investigative committee agenda, which meets quarterly. And so it would kind of depend on, when the allegation letter went out and what it meant meeting it gets on. I mean, if it's something where there's clearly nothing there, it's reviewed. Oh, it's also reviewed by the medical reviewer. I mean, it can be closed in a matter of a few months, but sometimes it takes longer depending on how long the doctor takes to respond. There are some that we have to request multiple times for response. And then also there are times that just when the timing of it, we get it just before our investigative committee, and so it's going to have to wait at least 3 months. And it's really up to the investigative committee, because depending on what maybe the records show and other things, they may ask for a peer review. And so even if this is the only allegation initially made, the investigative committee could want to expand it. So it's not always, I would say, as cut and dry as you're proposing. And, and so I would say a few months to potentially a year would be the time frame for the investigation. We do our best to keep the physician informed, or the physician assistant or other licensee during that process.
Thank you, Ms. Bradley. And thank you, Senator Hardy, for your interest in this topic. As this is not the hearing for this, I would just encourage you to get the hearing date when it gets scheduled. And I think these questions are great questions to bring up to the board as they consider this regulation. We're going to go ahead and move on to our next agenda item. Thank you again, Ms. Bradley, for your responses today. Our next agenda item is agenda item 5, which is an overview of child welfare, child maltreatment prevention, and youth homelessness. I have a couple folks, primarily from the National Conference of State Legislators, to discuss this issue, and it looks like they are all online. I'm going to go ahead and let you introduce yourselves, and please proceed when you are ready.
Thank you. Good morning, and thank you, Chair Peters and the members of the committee for inviting us to speak with you all today. We will be presenting on child and family well-being, child maltreatment prevention, child welfare, and youth and young adult homelessness. For the record, I'm Jill Yorty, a senior policy specialist with the National Conference of State Legislatures. I'm joined for this presentation by my colleagues Heather Wilson and Cameron Rifkin. And I'm going to share my screen here so we can see our presentation. So in this presentation, we will give a brief overview of NCSL, discuss high-level themes around child and family well-being, including child maltreatment prevention, give an overview of child welfare and foster care trends, and talk about trends and data surrounding youth homelessness in Nevada. Finally, we'll wrap up by connecting back to what research suggests children and their families need to thrive. The National Conference of State Legislatures is a bipartisan organization serving legislators and legislative staff in America's 50 states, territories, and Washington, D.C. The organization creates opportunities for lawmakers and staff to share knowledge and ideas so they can enact laws and policies to improve the lives of their constituents. NCSL also ensures states have a strong, cohesive voice in the federal system. With a strong belief in the importance of the legislative institution, NCSL knows that when states are strong, our nation is strong. Now I'll hand it off to my colleague Heather Wilson to talk about child and family well-being in the context of the child welfare system.
Thank you, Jill. Good morning, Chair, members of the committee. Heather Wilson with NCSL, National Conference of State Legislatures, for the record. Today, I'm going to start talking about some key national themes and trends and messages that we're seeing throughout the child welfare field. One is child well-being is inextricably linked to parental well-being. Children do better when their parents do better. Two, that this work is interdisciplinary and the issues are intersectional. Children and families need emotional and economic supports to thrive. These broad indicators of well-being take a village, so to speak, of public, private, and community support. Next, prevention occurs on a continuum. Child welfare systems and agencies across the nation are actively working to move upstream to prevent child abuse and neglect. This work is generational and happens on a continuum to disrupt the cycle of generational trauma for families. And finally, data trends reveal that families of color are disproportionately represented across child welfare systems. So racial disproportionality occurs at nearly every major decision-making point across the child welfare continuum, from reports to screened-in cases to out-of-home placements. Another trend that you will see is predominantly very young children, particularly those under the age of 2, are enter into the child welfare system. Slide. So to help prevent some of these traumas and to support families, the Center for the Study of Social Policy established a research-based approach to strengthening families and identified 5 interrelated protective factors that studies show are related to decreased likelihood of child abuse and neglect, as well as to the promotion of family strengths and optimal child development. Those factors include concrete supports in times of need. Families need stability in housing, in food, in transportation, in healthcare. Knowing that you are able to care for your children significantly reduces anxiety. Another protective factor is knowledge of parenting and child development. Really understanding the unique aspects of child development, implementing developmentally and contextually appropriate best parenting practices. Successful parenting really fosters psychological adjustment as well as helps children succeed and thrive. Next, parental resilience. Managing both general life and parenting stress and functioning well when faced with stressors, challenges, or adversity. Stress can make it harder to parent effectively, so helping parents develop resilience helps children thrive. Next is social emotional competence of children. So children with strong social skills get along better with others. Parents are their child's first and most important teacher. Finally, social connections. Having healthy, sustained relationships with people, institutions, and the community are a force greater than oneself. Parents who have a social network of emotionally supportive friends are better able to care for themselves and for their children. Slide. And now knowing the protective factors allows us to work along a prevention continuum. We know that our bodies and brains can repair trauma and heal from adversity through positive interventions. So when we look at a prevention continuum, particularly in the child welfare space, we're talking about primary, secondary, and tertiary prevention. You may be familiar with these from public health form. So in primary prevention, we're talking about education and policies that are for an entire population to prevent trauma and to prevent maltreatment. Secondary are system supports, so those identified with risk factors to entering into our systems. And some of these interventions include public health or diversion programs and some child welfare voluntary interventions. And this is really to mitigate risk factors and promote family protective factors. And next is tertiary prevention. So this is deeper end prevention. So working with children and families who have already experienced harm to mitigate the impact of that harm and to prevent future harm. Now, With that, I'd like to pass it along to my colleague Jill Yorty to share some data and policy trends.
Thank you. Jill Yorty for the record. For this section of our presentation, we'll start with a look at how the Nevada data from 2020 compares to national averages. These data are from the 2020 Child Maltreatment Report that was released by the Children's Bureau earlier this year. While some states have already reported 2021 data, 2020 is the most recent year that we have access to data across a majority of states. You can see in this table that in 2020, Nevada's rate of children in foster care was 6.3 per 1,000 children in the population. This is higher than the national average. Nevada also has a lower rate of investigations at 40.1 per 1,000 children in the population. And of those investigations, a smaller percent are substantiated than the national average. Of these investigations that were substantiated in Nevada, 83% involved neglect and 21% involved physical abuse. Both of these are higher than the national average. Finally, 7% of substantiated cases involved sexual abuse. This is lower than the national average. When child abuse or neglect has an investigation that is substantiated, there is determined to be an immediate threat of harm to the child. Foster care is one of the most well-known types of intervention when a child is taken into state custody. Foster care refers broadly to when a child is taken into state custody and placed with a foster parent or family. The type of placement can vary depending on the needs of the child. And so there are multiple different types of foster care that are licensed by the state. Traditional foster care involves the child being placed in a home, usually with somebody that they don't know. Kinship care is when the child is placed with a relative, often someone who already knows and loves the child. Therapeutic foster care is a specialized type of placement where the foster parents have additional training to support children who require a higher level of services or supervision. And finally, respite care and emergency placements are shorter term placements designed to provide short-term care for children in state custody. There's been an important shift in many foster care systems to promote reunification of families so that children can be safely reunited with their biological parents, rather than remaining in state custody for extended periods of time. In both Nevada and in the United States more broadly, the majority of children entering foster care are under the age of 5 years old. And as my colleague Heather mentioned, most of these are under the age of 2. From this table, you can see that both across the nation and in Nevada, the majority of removals involve neglect. And in Nevada, neglect was listed as a reason for removal in 89% of those cases in 2020. This makes it important for policymakers and practitioners to understand neglect and its role in the removal of children from their families. You can also see here that in Nevada, during 2020, parental incarceration and parental substance abuse are listed as reasons for removal in more than 10% of cases. For parental incarceration, this is higher than the national average, and for parental substance abuse, this is lower than the national average. Next, I'll briefly cover 3 major pieces of federal legislation that impact state policy surrounding child welfare and child maltreatment prevention. The first is CAPTA, the Child Abuse Prevention and Treatment Act. This was enacted in 1974 and provides federal funding and guidance to states in support of prevention, assessment, investigation, prosecution, and treatment activities. CAPTA also provides grants to public agencies and nonprofit organizations, including Indian tribes and tribal organizations, for demonstration programs and projects. There is currently a reauthorization under consideration by Congress. The next is the Indian Child Welfare Act. This was enacted in 1978 to protect the best interests of Native children and promote the stability and security of tribes and families by establishing minimum standards for the removal of Native children and placement of Native children in homes which could reflect the unique values of Native cultures. ICWA, the Indian Child Welfare Act, provides guidance to states regarding the handling of child abuse, neglect, and adoption cases involving Native children. Given that Nevada has 20 federally recognized tribes and a native population of just over 32,000, this is a piece of federal legislation to be aware of. The final one is the Family First Prevention Services Act. And I'm not going to go into much detail on this one because I know that you have a wonderful presentation coming up after ours, specifically on Family First. Finally, I'll go over a few trends that we've seen at NCSL regarding state policy across the nation. The first is that many states are revisiting how neglect is defined. In part, this is in response to our understanding that most removals occur due to neglect. The national definition of neglect is quite broad, and states and territories generally have their own definitions of what constitutes neglect. Recently, a number of states have been revisiting this regarding things like separating poverty from neglect as a reason for removal, or to add things like parental substance abuse that impairs a parent's ability to care for their child. The next trend I'll mention is attention to oversight and administration. These often relate to the emergence of new information or understandings about adverse impacts that children in care experience and attempts to remedy those situations. The final trend we want to bring to your attention is the emphasis on preventing children from entering foster care in the first place. Research has shown that even when it is necessary for safety, separating a child from their parents is a traumatic experience. This is part of why we see a major shift in recent years toward the idea of preventing children from entering foster care. We also know that prevention efforts have substantial cost savings to states in many cases in the long run when compared to reactive interventions such as foster care after abuse or neglect has occurred. Next, my colleague Cameron Rifkin will talk about youth and young adult homelessness.
Thank you, Jill, and thank you all for being here. As mentioned, my name is Cameron Rifkin, and I am a policy associate with NCSL. I am here to talk a little bit about youth and young adult homelessness. So nationally, there are over 34,000 youth ages 18 to 24 experiencing homelessness each night. This does disproportionately affect people of color and LGBTQ youth. Nevada has one of the highest rates of unaccompanied youth homelessness. Depending on the year, it kind of ranges, but recent data has shown that Nevada ranks 4th for unaccompanied youth experiencing homelessness and 1st for unsheltered unaccompanied youth. So current data shows that 570 unaccompanied youth are on the streets in Nevada each night. In Southern Nevada specifically, youth make up 22% of the total population experiencing homelessness. The national average is 6.54%. It is important to note that accurately measuring homelessness can be difficult and that these numbers are usually considered an undercount. Next slide, please. Potential strategies that policymakers have explored and enacted in recent time include drop-in centers. These have shown to have better outcome for youth experiencing homelessness, including higher educational attainment, stabilized housing, and improved health. Drop-in centers usually involve areas where youth can come to charge electronics, get a hot meal, perhaps use the restroom, shower. Some drop-in centers do operate nighttime shelters. Others are just day facilities where folks can come and connect. Another is consent and access to records and healthcare, specifically access to their vital records and medical care without parental consent. And this is to reduce administrative barriers and limit the red tape that youth experience while they're homeless. So Nevada recently did pass a piece of legislation related to this, healthcare access for unaccompanied homeless minors without parental consent. An additional strategy is expanding services for transition age youth and youth in foster care. So the Family Unification Program vouchers, these are vouchers for youth 18 to 24-year-olds, young adults who have exited the foster care system. The voucher cannot exceed 36 months. Additionally, these family unification program vouchers are extended to parents or caregivers who are at immediate risk of losing custody of their children due to housing stability. So if their housing situation is the primary cause for the removal of children, they are also eligible to receive these particular vouchers. Next slide, please. We'll talk a little bit about the intersection of education and youth homelessness. And so the McKinney-Vento Act is the primary federal legislation related to students experiencing homelessness and their rights. It outlines, requirements that states and school districts must abide by for their students experiencing homelessness. And so these funds are distributed by the Department of Education to states, who then allocate them through subgrants to school districts. And we have seen a few pieces of legislation recently in Nevada dedicated to expanding services for students experiencing homelessness. There was one in 2021 and a pair in 2019. The one in 2021 requires the consideration of the effects of homelessness in suspending or expelling a student from school. So a student's housing status must be taken into consideration before they are removed from school. In 2019, there was a piece of legislation that requires schools to assist students experiencing homelessness and students in foster cares with earning full or partial credit for their coursework. Again, this is focused on improving educational services for youth experiencing homelessness, which can be a significant protective factor for mitigating youth homelessness. The final piece in 2019 was dedicated to post-secondary school. So those first two pieces were focused more on K through 12 education. And this final piece is dedicated to creating the position of the liaison for post-secondary education for homeless pupils. So that's a little bit more focused on post-secondary achievement. With that, I will be passing it back to my colleague, Heather Wilson, to close this out. Thank you all again for listening.
Thank you, Cameron. Chair, members of the committee, Heather Wilson, Senior Policy Specialist with the National Conference of State Legislatures, for the record. Today, you are going to hear a lot of really hard data points and statistics throughout the day. So I want you to remember the hopeful and preventative efforts that tools and policies and practices and programs that we have to support children and families before they experience harm and to mitigate the impact of that harm. So Dr. Bronfenbrenner of Cornell University said, children don't grow up in programs, they grow up in families and communities. So as you listen to presentations today, and you hear some very hard facts and data, just remember that children do better when their parents do better, and we can move upstream to prevent child maltreatment. Thank you. I'll now share a few additional resources and our contact information if you have any follow-up questions that we don't have time for today. And then some of the resources that we used during our presentation that you should all have access to, as well as other helpful pieces of information. And with that, I will turn it back to the chair and be happy to answer any questions that you might have.
Thank you so much. Thank you for that presentation. I really appreciate in all of our meetings, we have started with a baseline. And I think that that's really important for us to understand and all be on the same page about what the efforts that are occurring in our state look like compared to the baseline data. I think we do have some time for questions, but I want to just extend that a lot of the upcoming presentations will talk about Nevada-specific programs and agencies that are dealing with these issues, and they may be more likely to answer your questions in in an effective way for policy building if you're interested in this area. I will take a couple of questions, but we will move on to the next agenda item shortly. Dr. Titus has a question up here in Carson. If other folks have questions, please raise your hand or turn your mic on when it is time. Go ahead, Dr. Titus.
Thank you. Thank you for the question and thank you for the presentation. Can we go back real quick to, I think it was slide number 10 or 11 where you had a 22% homeless rate. I just needed some clarification on that.
I believe that was slide 10.
10, okay.
Yes. So in Southern Nevada specifically, of all of the people experiencing homelessness, 22% of those people experiencing homelessness are youth ages 18 to 24. The national average is 6.4%.
All right. And so I was wondering.
And thank you for your question, Dr. Titus. I'm sorry if that did not answer it. I'm happy to provide further elaboration.
Well, so again, you repeated what was on the screen, and I appreciate that. But maybe you could send us, all of us, and to the staff, and they can get it to us, where we can find the data or the charts on any particular trends, and because I'm curious about where the homelessness is scattered throughout Nevada. If 22% of people are experiencing homelessness in Southern Nevada, are youth, maybe we need to see kind of a relative, because that's a point in time number, or have we always been number one on our unaccompanied youth, not sheltered? And so I'd like to have some more information on those kind of statistics, because it's only relevant at one point, and it would help me, and I think maybe members of the staff, and maybe after your presentation, the state people will be able to give us some better data on what's the trend in Nevada, where are they scattered, those kind of information. I see somebody in the audience maybe shaking their head, so maybe we'll get some more information on this, but I need a broader span of reference.
Thank you for that comment.
That's Dr. Titus. Thank you for that. And Cameron Rifkin, for the record, I apologize for that. At Policy Associate at NCSL. Yes, I would agree to defer to some state experts later on in this call to provide a little bit more insight. I do believe they're hyperlinked in the presentation, so you'll get a copy of that. The studies we located were by UNLV, the United States Interagency Council on Homelessness, and then the Nevada Homeless Alliance, who I think is that specific data point that you're referring to. And I, from our initial research, understand that there is a heavier concentration in Southern Nevada compared to the rest of the state and compared to national averages as well.
Yeah, thank you for the question, and I do believe that we'll get some of those answers today, but there are other resources out there, such as the Nevada Homeless Alliance, that I believe staff would be more than happy to help connect you with on those statistics and information if you'd like a follow-up on that. Are there any other questions from the committee before we move on to the next agenda item and presentation? I do not see any. Oh, I see, sorry. Dr. Ornlicker, please go ahead.
Thank you, Chair. And I was surprised by the data. It's the foster care reasons for removal slide. And the data indicate that in reasons for removal, we're well below the national average on parental substance abuse, which seems inconsistent with that we have generally higher rates, I think, of substance abuse. And also that our neglect rate is much higher. So I would have thought that might reflect parental substance abuse in large part, but apparently it doesn't. So what might drive our higher level of neglect?
Through the chair, thank you, Dr. Ortlicker, for that question. I know from a national perspective, sometimes parental incarceration can be included in that definition of neglect. And so it would come down to how those cases are classified by agency personnel. And for Nevada specifically, I would defer to agency personnel who would be better able to answer that question of how those cases are classified.
Thank you for that response. And I do believe that we will have a presentation in a little while from CPS. So hopefully, let's hold that question. We can ask them about those statistics as well. Are there any other questions from the committee before we move on? Not seeing any, so if I missed you, please pop your microphone on and let me know. Otherwise, we will move on. Thank you so much to our folks from NCSL. Really appreciate you being here and providing us with this kind of baseline and ideas to start us off on our presentations for today. We appreciate you being here. Thank you. All right, we're going to move on to agenda item 6, which is our presentation on the Family First Prevention Services Act of 2017, which relates to family services and foster care and its implementation status in Nevada. It looks like we have some folks in Southern Nevada to do this presentation. I did not see who exactly it was, so I apologize. Please introduce yourself and proceed when you're ready.
Good morning, Chair Peters and members of the committee. My name is Cindy Pitlock, and I serve as the administrator of the Division of Child and Family Services. And excuse me, throughout the day, you're going to have hopefully a really great presentation that builds upon another and yet builds upon another. And I will be here all day to add support and answer any questions as necessary with my team and also my stakeholders and colleagues that will be presenting today as well. So I'd like to introduce Dr. Dominique Rice, who is Deputy Administrator of Division of Child and Family Services, and she's going to educate us on the Families First Prevention Services Act. Thank you.
Good morning, and thank you, Chair, for giving me this time to talk about the Families First Prevention Services Act. As mentioned, I am Dr. Dominique Rice. I'm the Deputy Administrator over Quality and Oversight for the Division of Child and Family Services. Next slide. Today we will be discussing an overview of the Family First Prevention Services Act, the Families First Prevention Services Act benefits to Nevada families, the funding specific to Families First Prevention Services Act, any requirements we have to abide by for Families First, as well as Families First Prevention Services Act implementation status in Nevada. Next slide, please. Next slide. The Family First Prevention Services Act was passed and enacted by Congress in 2018 with the focus on the goal to enhance support services for families to assist children for staying in their home, reducing the use of congregate care, and to build the community's ability to provide supports to children and families. Next slide, please. Families First Prevention Services Act Bipartisan Budget Bill of 2018 highlighted specific requirements placed on out-of-home placements, prevention services, and care of older youth. With out-of-home placements, Title IV-E federal funding payments were no longer allowed to be used beyond 2 weeks for residential child care facilities, with the exception of specialized care settings and populations. The family foster homes will now need to meet new federal standards in order to be recognized as family foster homes. With prevention services, Title IV-E federal funding now allows states to fund services for in-home parent skill-based programs, mental health, and substance abuse prevention and treatment. These services would be put into place to prevent placement of children and youth into foster care systems. Chafee funding can now be used for services for youth who have aged out of care within the system up until the age of 23 years. There are also education and training vouchers that can be used up until the age of 26 for youth. Some other requirements for Family First Prevention Services Act requires the documentation of youth who previously were in foster care. The responsibility of ensuring prevention services activities do not increase the juvenile justice population, and that background check requirements are enacted as well. Next slide, please. With the various changes in Family First Prevention Services Act, there are still some areas that have not changed. The Title IV-E continues to remain a federal retirement program specific to children involved in foster care and who meet the financial eligibility criteria. Title IV-E still allows for administrative and training dollars to assist with costs, and states are still required to spend their own funding to provide support to child welfare, including prevention services expenditures. There are still some exceptions to Families First, such as it does not represent new money. It instead allows the ability to utilize Families First Prevention Services Act federal funds to be more accessible to children, youth, and families. Our states still will have to continue to submit plans to the Children's Bureau and track entitlements and expenditures. And last but not least, Title IV-E is a last resort payer. Medicaid funding should be utilized prior to the use of Title IV-E funding. Next slide. The ability to access federal prevention service dollars, states must adhere to the following stipulations. They must have an approved 5-year prevention plan, adhere to the residential child care and qualified residential treatment provider standards, ensure at least 50% of services provided to the population served meet the definition of well-supported services, and services provided are trauma-informed. The services chosen by the states must be evaluated if their designation is promising, supported, or well-supported practices, unless the states receive a federal waiver of requirements. The prevention services must be available for up to 12 months at a time to children and youth who are candidates for foster care and or pregnant or parenting children, youth in foster care. Children and youth who receive prevention services must have a prevention plan in place that identifies the specific prevention strategy for the child to remain at home or with a kin caregiver. And a list of services planned to be provided are also needed to be documented to ensure the success of prevention strategy. Next slide, please. Families First has made some changes related to out-of-home placements as previously shared in an earlier slide. There are new federal standards related to family foster care homes that include eligibility standards to become a foster parent, identification of capacity within the home, the sleeping arrangements, any emergency preparedness plans, and plans for transportation, to name a few. States will not be allowed to use Title IV-E reimbursement for youth and children placed in child care institutions beyond 2 weeks unless child care institutions are providing one or more of the following: a program for pregnant or parenting youth, independent living program for youth aged 18 and older, specialized programming for youth who have experienced or at high risk of human trafficking, residential substance use treatment programming, or a qualified residential treatment program. Next slide. Here are some of the benefits to Nevada. It allows more flexibility to claim additional federal funds for prevention services, administrative costs, as well as training costs. It also provides a framework to expand services and focus on providing them in a family-based setting when an out-of-home placement is needed. Next slide, please. Title IV-E is entitlement funding, so Nevada has to submit the necessary forms and plans to obtain approval, and then we can submit for reimbursement for up to 50% for all eligible children and services. In fiscal year 2019, Nevada reported a functional reimbursement rate of 25% based on the number of children and families eligible in the services. The requirements vary by components of Families First, but most require additional plans to be submitted and approved to the Children's Bureau, and additional reporting of data is also needed. Next slide, please. Next slide. Our current timelines for implementation are staggered, with deadlines beginning or starting in 2018 and continuing through 2027. Some activities are optional and others are mandatory that we have to meet. Next slide, please. At this present moment, the State of Nevada Division of Child and Family Services have worked towards the following Families First requirements. We have submitted for final review to the Children's Bureau proof of foster care for youth as an automated letter, and we are working with the agencies to ensure the letter is provided to all youth in foster care. We have submitted for final review to the Children's Bureau a waiver for non-safety licensing standards to model our licensing standards for foster family homes. The remaining requirements of this standard is aligned with the Children's Bureau expectations. We are currently in the process of completing the certification that provides Nevada with prevent increases to juvenile justice populations. Once we are able to finalize our Title IV-E plan and Title IV-E prevention services plan. Next slide. We have submitted to the Children's Bureau for final review. The Division of Child and Family Services and the jurisdictions is tracking each of the placements for children, and we are ensuring ineligible placements are not claiming reimbursement for Title IV-E, which will keep us in compliance with the limitations specific to placements that are not family homes. We are currently in the process of working with each of the jurisdictions for designating programs. The Division of Child and Family Services and the jurisdictions are currently working on a qualified individual review process. We have submitted a waiver to the Children's Bureau to provide flexibility in the designation of a qualified individual to meet the qualified residential treatment program requirements. We initially submitted our Title IV-E Prevention Services Plan, which is an optional component of Title IV-E, in August of 2021. We have received feedback from the Children's Bureau regarding our plan and are currently making modifications with a goal of resubmitting our plan during the summer of 2022. Last but not least, we have submitted to the Children's Bureau for final review our electronic system that meets the requirements of the electronic interstate case processing system. Next slide, please. The Family First Prevention Services Act focuses on the below candidates for foster care. Children and youth at imminent risk of entering foster care who can remain safely at home or in kinship with services who, 1, is in present or impending danger, and or has one or more of the identified negative family conditions, but not necessarily meeting present or impending danger criteria that suggests an increased likelihood of entering foster care, and or has a reunification, adoption, or guardianship arrangement that is at risk of a disruption or dissolution that will result in foster care placement, and or is under 26 years old, is pregnant and or parenting, has a history of being in foster care, and is not currently in foster care with a need that could result in foster care placement for the child or children, and the pregnant parenting foster youth. The Family First Prevention Services Act interventions focus on in-home parent skill-based programs and services, mental health programs, substance abuse programs, and services. Next slide. The Families First Prevention Services Act model plans for child and family outcomes to increase caregiver well-being and protective capacity, increase family stability, increase child well-being, reduce mental health disorder symptoms, and increase family engagement. The model also looks to improve process outcomes specific to ensure interventions achieve their desired outcomes and provide increased access to specific interventions based on the population. The overall long-term outcomes the Families First Prevention Services Act model looks to reduce rate of foster care entry, reduce the rate of foster care re-entry, reduce the total number of youth in foster care as well. Excuse me, next slide. The important drivers to implementation include that we focus on training and workforce supports, public and private partnerships that we presently hold and continue to build, data collection and analysis, continuous quality improvement and involving our evaluation teams, involving and engaging our stakeholders, internal and external, developing a clear communication plan, interagency collaboration, and leadership support. Next slide, please. Our current activities as it relates to our prevention services plan include reviewing and revising the process for care planning and safety reviews for children, youth, and families that are not being served in the child welfare agencies. We are finalizing the list of evidence-based practices that we will include in our Title IV-E Prevention Services Plan. We are presently working with providers to develop installation, implementation, and sustainability plans for evidence-based practices. And finally, we are collaborating with Nevada partnerships to develop training for public and private workforce, families, and other stakeholders on key components of Families First Prevention Services Act. Next slide, please. Our next steps. Presently, we are planning to resubmit our Title IV-E plan and Title IV-E prevention plan to the Children's Bureau for final review and potential approval. We are currently reviewing our cost allocation plans and will be updating these to align for resubmission to the Children's Bureau in conjunction with our other two plans. The fiscal and information technology leads from each of the jurisdictions, including the Division of Child and Family Services, will continue to meet on a regular basis to ensure that infrastructure is ready to implement all components of Families First Prevention Services Act. And our priority continues to be the safety, well-being, and permanency of all Nevada children, youth, young adults, and families. Next slide, please. This concludes my presentation. I'm happy to answer any questions, and I will pass it back over to our chair. Thank you.
Thank you so much for that overview, Dr. Rice. Really interesting work going on, and I have questions, but I'm sure my committee does as well. So I'm going to go ahead and start with committee questions. If there are some, please raise your hand or let me know. Unmute your mic if I'm not seeing you. I'm going to go ahead and ask my question then. So I'm trying to get my mind around where implementation is, and you gave a brief overview, but can you speak a little bit to the status of implementation and some of the metrics of value that are that you're using to ensure that these are implementation is bringing value to the state? And then can you also talk about some of the barriers that you've experienced in designing these implementation plans and what those look like right now?
Thank you, Chair. This is Dr. Rice for the record. As of now, our current implementation is involving more of policy development, implementation on a state level, and also working with our jurisdictions to ensure they are also developing policy specific to their jurisdictions. We are also in conjunction and working very closely with the Children's Bureau to ensure that our policies are aligned with federal requirements. Barriers to that is really truly understanding the direction that the federal government is guiding us towards in the larger picture. As we're communicating, the Families First Prevention Services Act is a large change in certain areas, and being able to identify various areas that we have to implement, such as the QRTPs, the Quality Residential Treatment Program, QRTPs, and where we're able to get those up and running and implemented. So that takes time, as well as we're working with our jurisdictions to get those implemented. So more behind the scenes on our infrastructure side of getting it created before we can actually implement it for it to be beneficial to our families is where we're presently at. Also, obtaining approval through the Children's Bureau is another barrier, as we're working with the court improvement program to get administrative court rules in place in order to be sure we're aligned with QRTPs.
Chair Peters, if I may.
Please go ahead. Thank you.
For the record, this is Cindy Pitlock, Administrator of the Division of Child and Family Services. So this is a really tough concept, this families first concept to wrap our minds around. But at the end of the day, the bottom line is it's prevention services for families to keep them out of foster care or advancing in our system. My shameless plug would be that this is a huge lift. It's a huge lift for the state of Nevada. Huge lift staffing wise. At the end of all of this, the light at the end of the tunnel is we'll have an awesome program of prevention across the state of Nevada that will align with federal requirements and also give the state a robust funding mechanism for these prevention type programs. But it truly is a huge lift staff wise for the division. And thank you for hearing our presentation today.
Thank you for that. I actually was going to ask about how you were feeling about your staffing ability to meet these metrics and goals. I've been thinking a lot, this is not isolated to your division, a lot about how we ensure that our state agencies are staffed sufficiently to meet the goals of our state, our growing population, and our growing state needs. So can you give us a little idea of what you're looking at staff-wise, and if we can be, if you are looking at that funding going into additional staffing needs as this implementation plan goes forward?
Thank you, Chair Peters. For the record, this is Cindy Pitlock. Yes, we're all really in the same boat, and we all realize that the staffing struggles are immense. I think at my division, we run right now at about a 36% vacancy rate. So if you really look at that in context, the potential of 1/3 of the division's work may not be getting done unless it's getting done outside of hours, overtime, and stretching our staff beyond the limits that they can handle. So we have to certainly be transparent about our challenges. Fortunately, I have a committed staff that is doing everything in their power to step up to get Families First implemented. We're considering leaning more in on our technical assistance contract and also maybe bringing in some extra help as we can. And Director Whitley is absolutely invested in Families First and its success and has agreed in every way to partner with me to make sure that we succeed. But yes, the challenges are immense. Staff is exhausted at best, but we will march forward. This is a great program for the state of Nevada and the youth of the state of Nevada, and ultimately we want to prevent advancing into a higher level of services, and this is part of that build. So we are also, of course, in the middle of budget build, and we know that the sustainability of Families First needs to be wrapped into that. And we're working closely, of course, with the director's office and all of our stakeholders to collaboratively really figure out how we're going to stand this up in the most robust way, but also keep it sustainable. And I'm not sure if Dr. Rice has any other comments or if I pretty much wrapped it up in a package for you. Thank you.
Thank you so much. I really feel for where you're at. I think especially for regulatory agencies that have that quality control metric, it is very difficult to ensure you have enough staff to meet those needs, which are the most immediate, right? Ensuring that our children are safe in the places that they're placed, that they're getting the resources they need at that place, let alone trying to develop a brand new implementation program. So we really kudos and thank you for your service in doing this and getting this program stood up. I hope that as we move forward, that if there are policy needs that you have from us, you submit recommendations for our committee to consider. We really are looking to support you in this effort. Keeping kids and families whole is a huge part of our goal, I think, in this committee. So thank you so much for what you're doing. Are there any other questions from the committee on this presentation? All right, I'm not seeing any unless you want to raise your hand or turn your mic on. Okay, thank you again so much for being here and for this presentation. We are going to go ahead and move on to our next agenda item today. Agenda item 8 is our overview of commercially sexually exploited children in Nevada. This is another one of those topics that can get pretty heavy. What, did I miss something? Oh, I'm so sorry. I skipped agenda item 7. So we're going to move back real quick to agenda item 7, which is an overview of Nevada's child welfare system and child protective services. We have a few presenters, and this looks like it's going to be a pretty good presentation. I've got some folks up here in Carson. Thank you so much for being here, and we've got you queued up for your presentation. Please introduce yourself and begin when you're ready.
Laurie Jackson, I'm one of the 2 rural managers for rural child welfare that cover the 15 rural counties, for the record. Okay. Committee, apparently I'm technologically troubled here. And committee for having us come. I'm going to provide you a brief overview of Nevada's child welfare system. We'll touch a little bit on the funding, child protective services, foster care, and independent living for youth. Nevada's child welfare system is determined by population concentration. The largest concentrations, which are Clark County and which are Washoe County, provide their own child welfare services. These services are provided through a block grant that is appropriated by the legislators. And they are also provided an incentive grant to help provide those child welfare services in their urban counties. Rural child welfare is funded through federal grants and general fund. And I'm sorry, do you not see this? Like,
I think we lost the presentation.
Let me see if I can. Not sure if this one's mine. Specialized foster care.
There we go. We are seeing it up here.
Okay.
Are you seeing it in Clark County as well?
We are, Madam Chair. Thank you.
Great. Are you able to see it virtually, Dr. Ornlicker or Dr. Hardy? Or Senator Doñate, Vice Chair Doñate? Oh, I got a yes from someone on virtual. Please proceed.
Thank you, Laurie Jackson, for the record. This allocation and these incentive grants help the urban counties to provide child welfare services within their county. Child welfare normally, I think, is known as Child Protective Services, more colloquially as CPS, although there is much more to do with child welfare than just CPS. The next slide talks a little bit about how families and children come into contact with child welfare. This is an informative slide, and it always starts with a referral or a call from a concerned neighbor or mandated reporter that has a concern about a child. This particular journey can take them through with us providing services and leaving their homes, or it can necessitate with us having a stronger intervention if no safety services can keep the child in the home. As you can see on the next slide, it starts with child protective services if we have to take protective custody. Protective custody is a legal proceeding that is overseen by the Nevada Revised Statute 432B. It defines what is necessary for us to do for families and children to get them reunified within their home, which is always our primary mandate. It also has specific timelines, which you can see in the brief overview for the child welfare court process. This is a particular handout that is provided to our families because it's easy to read and understand a somewhat complicated process when it comes to court. Child Protective Services is the first step to the safety and well-being of a child. We work under Nevada Revised Statute 432B. An intake or an intake referral is that call from a concerned neighbor or mandated reporter that comes into a child welfare agency that talks about having a concern. These calls are entered into our Unity system, which is our SACWA system, which is our federally mandated child welfare database. These calls can be handled in one of three ways. Information only means it doesn't meet a statutory requirement for investigation or assessment. This may be something as simple as a neighbor calling and saying they hear their neighbor's child crying. Differential response is determined to address a more lack of resources situation where maybe a loss of a job has impaired a family's ability to pay their heating bill in winter, so their house is cold. These are referred to community partners to address those needs of that family. Lastly, a report that comes in may meet the statutory requirement for assessment, also known as investigation, although we prefer assessment. When it's assigned for an assessment, referrals are then referred to a child protective services worker. This slide is of particular interest that I want the committee to take a look at 2020. We know the pandemic had far-reaching effects on many states and many agencies. For CPS intake referrals, both here and nationally, calls dropped almost 10% over that time period. That was when children were out of school, were not seen by medical providers, were not enrolled or participating in community events, and that families were in their bubble, so even relatives and family members did not see them. The calls that we did receive, though, were much more severe in nature. The severity in nature, I believe in the other presentation, there was a question about neglectful treatment or physical injury. These are the two defined in statute that a parent can be found substantiated for. And to briefly answer the question that was asked around substance abuse, there are many factors that go into assessing substance abuse that happen before a child is removed from a home. Some of which are the severity of the substance being abused, the age of the child, protective factors such as family, sober adults, or people that can be placed in the home or work with the family to stop the removal of that child. Removal is always the last thing that we want to do to a child because of the trauma. If we do have to remove a child, and there aren't safety factors or a way to safety plan with the family, then the child will go into foster care. Foster care is defined as a temporary, short-term placement to address the safety effects or the safety factors that are requiring that child not to be in their home. It was never intended to be a long-term solution to family issues. There is a hierarchy that we prefer to use that's in the best interest of the child, as you can see. We prefer to keep them with a relative or fictive kin, someone they're familiar with, someone that lessens the trauma for them. After that is the family foster home or specialized foster care if it's needed, depending on the child's needs, their mental health or their behavioral needs. Group homes, residential treatment centers, and shelter care. On the DCFS.nv.gov website, there is a weekly updated census of children within the rural states, within the rural counties that are removed. Currently, or at the last point that I looked, which is about a week ago, we were at 393. The next slide focuses on licensed foster homes. Another effect of the pandemic was that across the board, if you look at the top line where it says statewide and it says licenses, you'll see that there's a decrease of licensed foster care providers or homes across the state during this period, but it's really marked during 2019 and 2020, where possible placements and bed availability was decreased throughout the entire state. This affected both the urban areas also. In the 2019 legislative session, AB 298 was passed. It's the Foster Home Recruitment and Retention Plan. This plan requires DCFS to post our retention plan on our website. The slide that you're seeing is our potential homes, or the homes that we would like to have in each of our areas, in our rural areas. It is divided by our district offices, which you can see on the left-hand column. Is District 1, the top is Elko, White Pine, Lander, and Eureka. These were calculated or figured out based on looking at removal rates, the removal of children that required specialized homes, like multiple sibling groups, and based on the number of homes we currently had. So you can see that for each of the district offices. District 2 is Carson, Douglas, Lyon, and Story counties. They are 3 of our more populous counties, with Lyon being the county that is actually increasing and is the 3rd largest county now in the state. These are the calculated homes that we would like to have gotten, but we did not meet our goal. We are building our budgetary request to address these deficiencies. For youth that come into care or that have contact with child welfare, we have an independent living program. Youth are referred to that program from age 14 to 21, regardless of when they have come into care. Our independent living program is funded 3 different ways, 2 federal grants. One is the Chafee Independent Living Grant, and the other is the Educational and Training Voucher Grant. The additional grant is the FAFI, which is the Funds to Assist Former Foster Youth, help fund those programs for youth to attain skills for self-sufficiency. You can see some of the supportive services that our community providers provide for our youth is obtaining high school GEDs or diplomas. It can be as easy, it can be as mundane as calling to figure out how to do laundry and how not to turn things pink. So they provide these services. It would be of note, though, for the committee to realize that these children form lifelong connections to these workers and that they will reach out long past the age of 21. For information, for support, and even to share life events. Legislative Bill 397 was passed in the 2021 legislative session, requiring us to look at extended foster care. That program is currently in a statewide work group with all the jurisdictions being to develop a comprehensive program based on the federal requirements. The division did have some successes and accomplishments. The committee will notice many of them, our successes, our accomplishments, and even our challenges that I'll speak about in just a moment, revolve around removing children in foster care. We have created, Washoe County has implemented 2 years ago the Safe Babies Court Team. It is an amazing program that is in multiple states that is to address safety factors that require children, especially young children, to be removed from their home of origin. We know that removal at any ages causes trauma, but for younger children, it can cause developmental issues also. This particular Safe Babies Court is also being piloted in Carson, and I believe it's going to be piloted in Clark, with an idea that we would love to expand it to all of our rural counties. Binti software and our foster care website are 2 things that we did develop over the pandemic. Binti software is specific to foster care licensing. My best allegation would be that it's like banking software, how that revolutionized banking. This is changing how we can do foster care licensing. It is limiting the amount of drive time that my 4 licensing workers, because I have 4 licensing workers for 15 counties, have to engage in. So they're able to limit that windshield time, and it has decreased our postage costs because this is something where they can take pictures of documents and upload it to Binti. It's an app that they can download, and it is very easy to use since many of our potential foster homes are somewhat older and not as tech savvy. We also have a dedicated website. We've included the the link for you all. If you'd care to look at it, it shows my 4 licensing workers, recruiter, and supervisor as a team, and it provides the information, frequently asked questions, a place to download forms, so that's where potential homes can go and current homes can go in order to obtain those without having to try and get a hold of a licensing worker. As I said, a referral for child welfare is the first contact that comes in from a call. We have a dedicated intake unit because that is the most important decision that gets made, is whether something is assigned or not. And the information that they provide us helps us to make better decisions on what's assigned and what is more diverted to differential response or not assigned. The division is undergoing or contracting to have an actuarial foster care rate completed to update our rates. They were last updated in 2006. There were some high points, even after the pandemic. We did 56 adoptions in 2021, and we're currently at 31 adoptions in 2022. Those are children that are now in their permanent living situation and out of the child welfare situation. Higher level of care was developed to monitor children and youth that were coming in and out of residential foster treatment centers to provide them the supports that they need when they're coming back and being placed in specialized foster homes or regular foster homes. And our clinical services are amazing. They provide therapeutic and consultative services to our 4 district offices, to our satellite offices, to every child. They staff every child within those offices, and also to the courts when they have a clinical question, as well as providers within the rural counties who are maybe not as proficient at understanding trauma and child welfare. But we are not without our challenges. And again, the loss of foster homes for all of us throughout this state has been somewhat devastating. For the rural child welfare, we are limited in the amount of foster care trainings we can provide. They are required to go through the licensing process, and it's a required element. But because I have that's only being able to be provided by my supervisor, myself, or my manager, we're limited in the amount of trainings that we can provide. We've seen an increase in the request for interstate compact for the placement of children. It's also known as an ICPC. That is a process where children in other custodies, in other states' custodies, can be placed in Nevada with a relative or with an adoptive family. Where we go out, we make sure that that home is safe, we do a home study, and then we monitor that placement for that other state, as they do for us. Our Legislative Council Bureau partners have completed an audit and found that we utilize relatives whenever possible, but there's not a lot of structure or the same amount of structure that we have for licensed foster homes. So we are implementing some more structure around that. We are providing training to our relative foster homes or fictive kin foster homes through Kinship Navigator. They have a training specifically for relatives because it is a dual role where you're providing safety for a child, but you're also dealing with your family member. And we're trying to reunify with that family member. There are limited, I think you heard that maybe in the other presentation, that there are limited transitional placements for independent living youth or extended foster care youth. One of the struggles is while we do have HUD vouchers, right now housing throughout the state is incredibly difficult to locate and very expensive. So it's very difficult, even with a voucher, to find a place that you can rent. Our vouchers at the most are, they pay a portion of the rent for that individual or for that youth. And lastly, there is a lack of services and service providers in rural areas. There's a lack of acute residential and community-based mental health providers in some of our more rural areas. Our strategies are to increase our use of effective technology, work smarter, not harder. We're doing the contract for the actuarial study because we believe that that will also help us to obtain more foster homes, since our base rates are low, but also our ancillary rates, and those are things like clothing allowances and things like that. We're utilizing the Kinship Navigator to provide relative and fictive kin training. We do use contractors to meet the needs of our foster care population when we need to. We are revising our procedures to provide better oversight to our relative and better support to our relative and fictive kin homes. We are working with Aging and Disability Services on dual licensing for intellectual and developmentally disabled and autistic youth to increase placements. And we are also collaborating with Carson Tahoe Hospital for expansion of their Mallory Center to take acute minors. As we've seen, it's problematic with the closure of one of the psychiatric hospitals in Reno, and there aren't others available within the rural counties such as Elko or Lander. Everyone has to come either to Carson or to Reno. Now, turn this off.
Okay, thank you, Ms. Jackson. Thank you, Chair, members of the committee, for having us here today. For the record, Ryan Gustafson, Division Director with Washoe County Human Services Agency. I will be fairly brief. I just have a couple of slides. It's going to focus on the successes and accomplishments for Washoe County Human Services Agency child welfare, as well as some areas that we continue to have challenges in and continue to work towards. So, some of the successes in FY21, we were able to reunify more than 250 children back to their families. We were also able to provide clinical assessment and services to nearly 850 children and family members. We have, as Ms. Jackson said, seen tremendous success in our Safe Babies program, which we've had operational for about 2 years in Washoe County, with a well over 90% permanency rate for children within 12 months of entering the Safe Babies program. We were able to finalize 87 adoptions in fiscal year 21 in Washoe County. And with COVID, we were sort of forced and took advantage of the opportunity to pivot and create a virtual training platform for incoming foster parents, successfully piloted 2 community-based emergency homes. And we launched a number of campaigns, including a fostering campaign, a suicide prevention campaign, safe sleep campaign, and human trafficking campaign. And next slide. Again, we do also have some opportunities to improve. I won't read everything that's on there and just kind of hit the highlights. We've seen a decrease in mental health services in the last year in Washoe County. I think that's really statewide. In Washoe County, we've been hit particularly hard as well. Most notably, the closure of one of our 2 acute psychiatric hospital facilities. AB 387 legislation, which is called Collaborative Pathways now, came about last session with the goal of keeping children from coming into child welfare care unnecessarily to get services. That's taking us some time to get off the ground and to implement as well. Reimbursement rates for mental health and behavioral health services have continued to be low, which result in a decrease in service options for children in child welfare. This includes foster care rates as well. We had some court activity that was backlogged and sort of slowed down multiple processes. That was in part, mostly in part due to COVID. And again, that impacts some of our processes. Fortunately, that is starting to resolve itself as we continue to move through COVID and past it. And finally, in Washoe County, we have some fairly significant transportation issues that continue to grow. That's particularly within the school district, creating difficulties keeping children in their schools when they come into care, which we all know that's really important to keep kids in their home schools. And so transportation around the county and the Washoe area has been exceptionally difficult over the last really year in particular. And with that, I think that I will push it over to Clark County. I think we have some representation down there to take on the next section.
Yeah, good morning, Chair Peters and members of the committee. Tim Birch, Human Services Administrator for Clark County, Nevada, responsible for the Department of Family Services. Next slide, please. So our format will echo that of Mr. Gustafson in Washoe County. We wanted to keep this succinct for you and give you an opportunity to ask us questions. But we do want to take a moment to highlight the enormous efforts of our staff and the things they've accomplished in dealing with these difficult situations. Our Southern Nevada Children's Advocacy Center, which got a NACO award in 2019, has continued its efforts by serving 1,848 children. These are young people who have been experienced sexual assault and have come through our system to receive forensic interviews in conjunction with law enforcement. And the SNCAC, their foundation, raised up money to continue making sure those young people get mental health care services there at that center free of charge to those families. Emergency housing, you heard a lot earlier about homelessness and the impacts specifically in Southern Nevada. We have been able to work with our partners on the adult side of the service continuum and social service and house 72 families in emergency hotel motel situations. That has kept over 193 children just since December out of the child welfare system. Those children would otherwise come into our emergency shelter at Child Haven and been brought into the child welfare system. We've additionally used those beds to reunify 12 children and families back together. That we've had to use those because the family unification program, those FUP vouchers you heard about earlier, we have done a really good job with our local housing authority and maintaining 100% lease up on those. So we need more vouchers and we need more housing opportunities for our families. Prior to the pandemic, we worked with Legal Aid of Southern Nevada, we worked with other community partners, and we implemented a kind of a sibling bill of rights to make sure siblings are placed together whenever possible. And we're able to report to you that less than 3% of our sibling groups right now are placed separately due to lack of placement homes. Those are primarily due to treatment needs of those individual children. Additionally, you've heard talk about placing with family and how important that is. 47% of Clark County's placements are with kinship providers, and that far exceeds the national average. Which brings us to our kin gap and guardianships. To make sure that those relationships are supported financially, we doubled the amount of kin gap guardianships in 2021 over 2020. Commercially sexually exploited children, or CSEC, that obviously is something that is transitioning from a justice model to that of a victim model, and that is rolling over to child welfare. We have assessed this last year over 398 children that are at risk of being trafficked. 93 of those unaccompanied minors were returned safely home, and we've worked and we've begun already to fund some local partners to stand up beds. They're in the process of recruiting, training staff to open those beds for these young people. You heard earlier about the FFPSA and prevention services. We recognize that children under the age of 3 are disproportionately coming in, are the ones most likely to experience fatalities in our system. So we started a program a few years ago called Thrive by 5, where we take low-level interactions with our call center and refer those out to community partners to try to offer services early in that engagement process. And we, this last year, had over 17% of those 800 families enroll in voluntary services that otherwise would not have been available to them in an effort to try to keep them out of our systems. And on the far end of the spectrum, where children have come in our system, become wards of our system, over 550 adoptions were finalized in Clark County this last year, which even despite the pandemic exceed our 5-year average on that. I do, not on the slide, but I do want to recognize the efforts our staff have done around the aged-out foster youth. Again, you heard that alarming number around unaccompanied and homeless youth, 18 to 24, in our community. About a decade ago, the Department of Social Service took over the aged-out foster youth program. We just completed a 10-year look-back study with University of Nevada, Las Vegas, and showed that through the support services that we've offered, less than 2% of that population has become homeless over that time frame, which is in stark contrast to a national average of about 25%. Next slide. So moving from highlights to, again, opportunities for improvement and growth. Obviously, you all know years ago, the system was debifurcated and pushed down an opportunity for Clark County and Washoe County to be able to provide both ends, investigation and permanency services through adoption. And the block grant was formulated at that time to make the counties whole. We have grown dramatically since that time. I believe we've had one bump in about 2015 in that block grant. We anticipate this coming fiscal year to have to deal with a $29 million structural deficit to keep up with growth of our system and make sure that our families and children are safe. The foster care rates we already talked about earlier. I don't want to gloss over our child welfare responsibility for the CSEC, these commercially sexually exploited children. We right now have a $115 a day rate for a higher level of care, specialized foster care agencies. When we talk to other communities who are doing the work with these CSEC youth, they can be up to require 3 times as many resources to be invested in them to have successful outcomes. And that transition from a justice community to a child welfare model has not yet been funded. So that really stands as an unfunded mandate for us. And we seek, obviously, some conversation and assistance with that. Mental health really has framed the last several years for us, not just because of the pandemic, but because of lack of available resources in our community. One of the questions earlier was why so many neglect cases in Nevada compared to the national average. We code when a child has removed from an adult caregiver who is not receiving mental health treatment and is unable to care for a child, that goes into our system as a neglect. So that's one of the contributing factors there. We also recognize that in the last session we were charged with beginning to tracking the number of children who were surrendered into our system via AB 387, the Collaborative Pathways Program. This year, we've already had over 80 young people where parents have brought them into our system and surrendered them because they were unable to provide for their children's mental health. That puts us on track right now for well over 120 for the entire year if this keeps pace. We desperately need more assistance in mental health treatment and wraparound services for the children in our community so they don't wind up in deep end systems such as child welfare. To that regard, we do definitely want to thank the Interim Finance Committee for the $1.9 million of American Rescue Plan Act dollars that helped us fund I'm going to make sure I quote this correctly, an interim care facility for intellectually developmentally delayed children, so an ICF for IDD. The Board of County Commissioners just ratified the contract with the provider at Tuesday's morning's meeting, and we look to stand that program up in May, and we're thankful for all the support of the division staff as well in helping us move that project through. That will move children out of our emergency shelter who are lingering there because of their autism and other types of developmental delays that make them more difficult to place, especially when we're lacking the appropriate foster care homes in the community. We just want to echo the Medicaid rates. I think it was the main topic of a lot of the conversation at the Governor's Healthcare Conference that we went to earlier this week in dealing with providers as we challenged them to help step in and work with us to expand the systems of care for our families and children. That was obviously a major speaking point from them back to us, is that the reimbursement system needs to be re-examined there. And again, we do want to make sure that we highlight the efforts that all the teams have done around Families First Prevention Services Act. It's been several years of planning and moving that ball down the field. One of the things we are concerned about is without front-end investment, a lot of our providers, they've built their service models around the system as is. The ability to pivot and wait to get reimbursed is a business cost they're not yet able to undertake. So we're worried about the service provider community not being able to keep pace with the change in our government service provider model. So those are really kind of the big things for Clark County. And I would like to now introduce one of our community advocates, and I'll hand over to her if it's okay. And that is Ms. Kimberly Abbott from Legal Aid Center of Southern Nevada.
Thank you, Mr. Birch. And good morning, Madam Chair and the committee. My name is Kimberly Abbott. I'm a team chief with the Children's Attorneys Project at the Legal Aid Center of Southern Nevada. I'm also a certified child welfare specialist. I would also be remiss if I didn't thank Dr. Pitlock for encouraging a collaborative approach to today's presentation. So we appreciate the extension of the offer to come to the table and be part of today's presentation. If you're not familiar, Legal Aid Center of Southern Nevada is a nonprofit organization providing free legal services to low-income Nevadans, and we've been doing that since 1958. We serve Clark County residents in a wide variety of areas. However, one of our largest programs, which is the most relevant to today's discussion, is our Children's Attorneys Project. It's now more than 20 years old. We have 29 staff attorneys and a small army of several hundred pro bono volunteers. And with that, we represent every child coming into foster care in Clark County. A legislative change in 2019 clarified that children are parties in these dependency actions and entitled to counsel. So we provide direct client representation to the children. We're different from CASAs or GALs who represent the best interests of the children. I won't read you all the stats because you can see them there on screen, but I do want to just highlight that our education advocacy program is an important component of the work we do. They help ensure that children with disabilities in our system are getting appropriate education services, and we are very grateful that recently the IFC approved a funding increase that we believe will allow us to triple the amount of children served through that program, so we're very excited about that opportunity as we move forward. The slide, next slide, please. The slide has some of the highlights of our programs. One of the things we're very proud of is that we have 4 certified child welfare law specialists on staff. We only have a handful in Nevada, maybe 7 or 8 total. So we're very excited to be able to provide that expertise to the clients that we serve. One of our big accomplishments in coordination with Clark County Step Up, and thanks to some contributions from AT&T, was to be able to launch an innovative app for our older and aging out clients to be able to access community resources at the palm of their hand. I want to highlight for a moment just a couple of our future goals. We hope to continue to be able to collaborate with our stakeholders to make improvements to our system. Areas where we'd like to see some improvements are having a more trauma-informed system, a more family-centric system, and as Mr. Birch talked about, a more robust and fully developed array of mental health services for our youth. I know that this is a topic that this committee spent hours hearing about last month, but we cannot underscore the importance of fixing our gaps and further developing this system because the needs of our youth are not being met as we currently sit here. So we were grateful to be part of the Governor's Summit earlier this week, but we certainly still have a lot of work to collaborate and do together. What I'd like to do lastly is just to spend a minute trying to kind of talk to you a little bit about the human face of the foster care system. My colleagues have done an excellent job of talking to you about policies and statistics and programs, but I'd like to just give you a little perspective of child welfare from the children who are the users of our system. So if you'll indulge me, if you could imagine just for a moment that you were a newborn coming into this incredible world, taking your first few breaths of life, and with those breaths, you're met with pain and discomfort because you're in withdrawal, because your mom used heroin during her pregnancy. You spend your first few days on morphine in the PICU, and hopefully we found a foster family to come start visiting you and forming a bond with you. Now imagine you're a 3-year-old. You're found cold, dirty, hungry, and barefoot, wandering around an apartment complex on Boulder Highway. Your parents are passed out drunk, and they're about to be arrested for child endangerment. You go to Child Haven, our shelter, while the department is looking to locate some relatives. Now imagine you're 6 years old. It's the middle of the night, and you're with a CPS worker who's desperately trying to reach grandma to come get you. Your mom is in the back of an ambulance. Your dad is in the back of a police car. They were fighting again, and it got really bad this time. Imagine now you're an 11-year-old, and along with your 8-year-old and 5-year-old siblings, you were just delivered to a foster home. Your mom died of COVID last night, and you have no idea who's going to take care of you. Now imagine you are 16, and sadly you're back in the foster care system for a second time. Your aunt adopted you when you were just 2 years old, but as you've gotten older, she's struggled to meet your mental health needs and to help control your behaviors. You just spent the night in juvenile detention because you pushed her during an argument, and now she's refusing to come pick you up. I tell you these stories not to depress you, but because these are the realities of the children that we're dealing with in the foster care system. For the lucky ones, approximately half were able to locate relatives and fictive kin so they could go somewhere known to them. But for approximately the other half, they go to foster care. And what that means is they're going to live with strangers. So I ask you to imagine for just a minute what that feels like for them. They're in a new, unfamiliar place where the rules and the whole setup may be very different than anything they've ever experienced. The rest of the family may not look like you. They may speak a different language than you. They may practice a different religion than you were raised in. They may cook food that's very different from what you like or what you're used to. Pretty much life as you know it has been turned on its head. So for kids in foster care, uncertainty and instability are often the only certainty. At CAP, it is our honor and our privilege to walk this path with these youth as they move through this system, to try to be a constant and consistent force in their lives, trying to explain to them along the way what is happening, and to give them just a little bit of agency, a little bit of power, knowing that they have a voice that's being heard as these life-altering decisions are being made for them and about them in a system that often feels to them like they don't have a say or they don't have any control. Sometimes this path is straight and short, but way too many times it's long, windy, full of bumps, detours, and twists and turns. So as you make decisions and consider policies potentially impacting the lives of these children, we offer our organization to provide feedback, answer questions, inform you in any way we can from the perspective of the children that we serve, because after all, they are the intended beneficiaries of our system. Thank you very much.
Thank you all so much for the presentation. That was touching, Ms. Abbott. The description of the cases that you guys see, the scenario that children are put into, it's like a worst nightmare, I think, for a lot of parents, right? This will become a regular thing, you guys. I'm just going to cry at every meeting. Okay. I have some questions, particularly related to some of the audits that LCB has done related to your divisions and the foster facilities that we've seen either close or been on conditional actions. But I want to see if the committee has questions first, and go ahead and ask committee members. Please let me know if you have a question at this time. I see Assemblyman Orntlicker. Please go ahead with your question.
Thank you, Chair, and thank you all for the work you do. The challenges you face and the needs out there are enormous, and so I'm grateful for all you do. I wanted to pick up on one thing, Ms. Abbott, that you mentioned about the desire for a more family-centric approach. And that could be in two ways. So I'm wondering if you mean both or one more than the other. And that is more family-centric in the sense of when you do a placement, try to place with a relative, or family-centric in the sense that do more to keep the kids with the family. That I read some jurisdictions are criticized for being too quick to remove a child from a family, and that maybe we need to be more family-centric in that way. And then other jurisdictions are too slow to remove children from their families. So if you could elaborate on what you were thinking about with the more family-centric approach, I'd appreciate it.
Thank you for the question. And for the record, Kimberly Abbott with the Children's Attorneys Project at Legal Aid Center. I think I meant it in both and in a variety of ways. One, you will see from some of the information that Mr. Burge presented, I think we're making strides on some of these things. The increase in the kinship placements and the high number we have compared to other states in the country, I think is a fantastic development. Additionally, we've now have the ability to do our kin gap guardianships, which are paid guardianships, which give families other options. That has been fantastic, and it has been something that's been catching on and that we've been turning to more. I think for so long we looked at the option of either we get a parent help and they step up and do what they need to do, or we terminate their rights, and it was an either or. Guardianship gives us something that's a little bit in the middle because it allows the family to decide if that is a better legal mechanism for them. Sometimes grandma wants to be grandma and not mom, or auntie wants to be auntie and not mom, and guardianship provides another avenue for that. So we're happy to see a shift that we're exploring other alternatives. I think when we remove a child from a parent, although that may be necessary sometimes, it doesn't mean they have to be removed or disconnected for their entire family and the entire ecosystem that they knew. And I think we do a really good job at acknowledging our responsibilities to look for family. I think the problem is then when we find them. We're desperate to find a placement, and so we ask if they could take the child, and if they have reason and they say no, we kind of move on to the next person. But we don't stop on all the time and say, but how can you still be a support to this family? How can you still be a connection to this child? Grandma, do you still want visits even though you can't necessarily take placement? It happens in some cases, but I don't think systematically it happens enough. And then of course, as you referenced with Families First, trying to keep the family together if we can. Of course, I think we always have work to get upstream and to provide additional services and supports to the family so we can have less removals, because we all agree, I think, that when we remove a child from the home, it's traumatic and detrimental. Although it may be necessary, it doesn't change the fact that it's traumatic and detrimental to the child. I also think supporting kin placements, we can get them licensed, but it takes time to get them licensed. Other states have moved to situations where they pay first, license later. We don't start payments until after they're licensed. So, when we take a grandma who's on a fixed income and we drop 2 teenage boys in her lap who are going to eat her house out of house and home in the first 5 minutes they're there, plus they're going to outgrow their shoes every 5 minutes, right? That's a huge financial burden that she's taking on. And then we say, make time to go take classes and jump through these hoops and go through this process. So that's something I hope we can look at moving forward as well.
I'm really glad.
It's very helpful.
Thank you, Dr. Ornlicker. I'm glad you brought that up, because I think one of the areas that I'm interested in, what can we be doing to increase the interest, the public interest or private industry interest in, is really those support services, those community-based support services. What can we do to, and I hear you about reimbursement rates, and that is across the board, right? Assessing reimbursement rates. And I was listening to the radio on my way in today, and we're seeing that really increasing pay is being seen as one of the best ways to fight some of the losses we've been seeing over the last couple of years. So that's definitely out there. But I wonder, licensing-wise and also just outreach-wise, what are some things that we can be doing to make it easier or make it more inviting for public and private interests to participate in this area? And that is to all of you, if whoever wants to respond.
Laurie Jackson, for the record. I believe one of the ways is, and it was in some of our presentations, was to look at the Medicaid rates and the rates of reimbursement at how Medicaid reimburses and the timelines. What we hear is that compared to other states, it's relatively low, and that many companies or facilities have to wait a long time to be reimbursed. So I think that is also something that could be looked at to entice more agencies, more outreach to come to Nevada to experience. It's very beautiful here, and to experience opening homes and services here.
Ryan Gustafson for the record, and just to add to Ms. Jackson's comments, Some of the facilities and agencies that we've worked with, we try to keep kids in state, obviously, but there's not many in-state residential programs in Nevada. I think I can probably count them on one hand as far as residential treatment programs. Some of the out-of-state facilities have actually notified us that they won't work with Nevada and Nevada Medicaid because of timeliness issues and reimbursement issues. I think to add to your original question as well is I think it's important to not only look at the rates for foster families, because I could imagine the rate probably doesn't cover the meals right now for the kids, let alone anything else. I think that finding additional ways to support foster families and to obviously get additional foster families. I know within Washoe County, we try to do as much marketing as we can. We try to, team with community agencies, UNR, whomever we can to try to get the word out there that we need families and we need individuals to, foster, mentor, and adopt. That's sort of what we preach. But a lot of these kids go into homes and they need additional services. It is traumatic for kids to come into care, and when they do come into care, oftentimes, that can come with some weight, right? The loss of being with mom and dad, the difficulties of going in with strangers if it happens to be foster care. So some of those kids might need clinical or therapeutic services, and those are very lacking. I had referenced as well that we lost one of our 2 psychiatric hospitals. So when kids become acute, they are now going to medical hospitals where they're waiting to get a bed in the one psychiatric hospital that we have left. So that creates backlogs and that creates difficulties and just undue stressors for kids and families. But getting kids involved in therapy, getting them involved with community-based providers is important. And it's hard to do because many of them are backlogged and many of them have, quite frankly, caps on how many Medicaid clients that they'll see because they can get more money when they see third-party liability insurance clients or cash payers. So that creates difficulties. I know one thing we did, which you are all probably aware of, back in 2017 in October, we opened up our Family Engagement Center, which was really sort of radical and new countrywide. And one of the reasons we did that is we wanted our foster parents and our biological parents to be able to be in a home-like environment that's conducive to visiting, that's conducive to building relationships, because we've come to the realization that it's more beneficial for the biological parents to have a good relationship with the foster parents because they can teach each other a lot. And then when we can be part of that process as the child welfare agency, then it really becomes sort of like that three-pronged system where we have everybody working together, and then you're in a very homey, friendly environment where you can play games, where you can cook together, eat together, those things. And so I think if you can find new and unique community-based support and ideas to really bolster the foster parents and bolster the biological parents that are working hard to get their children back, I think that's what's really key into making the system successful.
Chair Peters, if I may.
Yes, please go ahead.
Tim Birch, for the record, from Clark County. I just want to highlight that we do work with community service agencies. I'd like to highlight Foster Kinship, actually as an agency, homegrown, with the assistance and leadership of Dr. Ali Caliendo, which has actually grown into a national model, and her program's under review to land in that national clearinghouse for FFPSA. So the investments do work when we're able to make them. I think we've beat the drum on needing more investment quite thoroughly. We do want to thank, we're always looking for businesses to come in and help incentive. A lot of times we hear that employees, potential foster parents have difficulty taking time off of work to go to all the hearings and things that happen during business hours that there need to be a part of to be a foster parent in there. So asking employers to incentivize in some way some leave banks for those their employees to get involved in this way is a really meaningful thing, and something we mentioned to our partners. And I'd be remiss if I didn't thank some, major local partners like the Las Vegas Raiders and the Golden Knights that have stepped in and done things as small as show up at community events to as large as recording welcome videos for our virtual foster parent trainings and out of relationship with some players who they themselves have gone through foster care. So I think the willingness to support is there. So I think one of the things we've asked in the past is also there's been great campaigns statewide for things like Home Means Nevada and other things. A statewide demonstrated commitment to foster parent recruitment through that level of campaign and messaging really helps because we as agencies are dependent upon the niceties of strangers and community partners to help us with a lot of that marketing and messaging because it's just not something that's built into our budgets.
Madam Chair, if I may.
Yes, please go ahead. And then I have a question from Dr. Titus.
Sure. Kimberly Abbott for the record. Dr. Pitlock reminded me of an important support. We actually spent a long time talking about this at the Provider Summit earlier this week. One way that we can support families, both foster parents and relative caregivers, is to have a robust respite system. It's important that our caregivers take care of themselves and have a chance to take a break so they don't get burnt out, so they don't turn away from this work. And so supporting a robust system to ensure they have access to appropriate respite is another way to ensure that we have quality caregivers.
I have to agree. And actually, the things that came up for me, even after reading the audits, was what do we do about ensuring that there is an access to therapy is one thing, right? Because that is a medical service, but cooking, laundry service, general cleaning services for these families to make sure that they're getting those basic needs met while they're caring for the kids and their emotional needs during the time that they're in those families. And that might be a part of that suggestion of how do we market that it's not really foster parents we're looking for, it's a foster community we're looking for, right? It's a community that's there to support the families. It's a community that's there to support children in getting to school and getting to therapy sessions and making sure that the households are taken care of. I think that those are things that we could get behind and find ways to bring community in on. And Dr. Titus has a question. Please go ahead.
Thank you, Madam Chair. Just real quick, especially in the rules, I've been on this healthcare committee now for 4 sessions, 8 years about, and foster care has been an issue the entire time. Over this process, one of the bills that was passed several years ago that I was very concerned about was the amount of training that a foster parent has to go through, and some of the sensitivity training and all of those. And I was concerned at the time that it may put further barriers into getting more foster willing to step up, especially in the rural areas. I'm glad to hear there's some virtual training so folks out in Fallon or out in Dyer or wherever it may be, because it's not just related to our urban areas. I mean, it's throughout the state is the issue, can get that training. So how have we seen any decrease in the number of families willing to be foster parents since we added the amount of requirements for training?
Lori Jackson for the record. I've not specifically seen decreases because of training. Usually our families are asking for additional trainings, like around trauma, around how to truly understand this child's needs, or mental health, because they've not experienced these mental health needs. What we have seen, I will defer to my colleagues, but what we have seen in the model home standards that were passed was there was a requirement for a flu shot, and there was, I believe, we still have a requirement for tuberculosis. It's little things like that are a little bit intrusive. So in our rural communities who are not always on board with getting specific immunizations, the flu shot seemed to be somewhat of a barrier. And I think that was seen throughout our jurisdictions. It was one more mandate. But I have not seen that training requirement has been a barrier to getting families. If anything, I think they enjoy it. They make connections to other families. And we at the Rules are actually looking to increase our post-training. So once you're licensed, we want to give you very specific trainings for the children you want placed in your home. And give you some guidance on what those trainings need to look like, other than just saying, well, you have to have 4 hours. So just go find 4 hours. So we're looking at making it much more specific to our current population that has much more specific needs.
And that might be virtual then, some of that training? that they have? Because I think that's just critical, not having to drive in and have that virtual. And then just to follow up on that, is there, again, in the rurals especially, but even in urban areas, is there some leeway when there's a crisis, this child has to get out of the home type of thing, to take them into a family member that hasn't been trained? So do you allow for that? Because they haven't looked at the foster system yet, but you need a place for this child. Do you take them into homes without the training? If it's a relative, do you have some sort of a leeway on that?
Yes, ma'am. Laurie Jackson, for the record. We prefer to place with family members, whether you're licensed or not. We do offer licensing to them once placement has occurred. We go to the homes, we take the child, we see the home, we have some safety measures in place so that we're just not sending a child to a family member. But we see that home, we talk to that family member, we explain our process to them and what's going on, and usually that it may be a somewhat more lengthy process than they're anticipating. They always think things can sort of maybe be solved in a couple of weeks, and that's not always the case. So that is always our first response. We do refer them. There is a joint program that came out with Department of Welfare, so that if a family member or fictive kin takes a child and they meet the income level, they can get some payment while they're going through the licensing process. And just to clarify, I don't think that I was clear, we also changed our format to an online platform so that we have panels, we have guest speakers, we have training, we have all those things in a format that everyone can access no matter where you are in Nevada.
Thank you for your questions. Are there any other questions from the committee that I missed? I'm not seeing any at the moment. I continue to have audit-related questions, but I think we could probably go over those when we meet in session and talk about what the status of some of those issues are, and the status of things like your actuarial study on rates. That'll be really interesting to hear about. And I think Medicaid is going through some actuarial analysis as well. So hopefully this next session we have some robust conversations about what actual payments look like over the coming biennium. Thank you so much for coming, and thank you all in Clark County as well. Appreciate you being here. We are going to move on to agenda item 8, which is the overview of commercially sexually exploited children in Nevada. Say that 3 times fast. We have Bridget Duffy here, I think probably in Las Vegas, there she is, to present on this issue. Please go ahead and introduce yourself and begin when you're ready.
Good afternoon, Chair Peters and members of the committee. I'm Bridget Duffy, the Chief of the Juvenile Division for the Clark County DA's office. I am up here by myself, and I don't know if my PowerPoint is coming up. Okay. Everybody can see it, right? Because I'm technically challenged.
We are not seeing it here, and I don't think virtually either.
Do you have somebody that can...
I can see the whole presentation now. Oh, and it looks like virtually we can as well. Thank you. Please go ahead.
Okay, so again, thank you, Chair Peters and members of the committee. Bridget Duffy for the record, and I am presenting to you today the overview of the evolution of our state's policy for the commercial sexual exploitation of children in Nevada. Presenting it as our past, our present, and our potential future. I want you all to know my professional title may make you wonder why I'm the one presenting today. I was basically volunteered. So I run the division for the Clark County DA's office that oversees children that are in foster care and in the juvenile justice system. And these children often fall within this realm of being our sexually exploited children. But I am an active part of our statewide commissions regarding the treatment and prevention and services to these children. And I've been doing that since 2015, and I've been an active part of the legislation. So I think I was selected, despite the fact that it's odd maybe that a prosecutor is presenting this, because I have that very long, extensive history of our past, our present, and now going into our future. So I have just a few slides to show you, and then I'll take questions. But I'm not going to go too far in depth in this because you heard a lot about the Family First Prevention Act earlier today. Our treatment of our children that fall within this sexual exploitation has a lot to do with the federal laws that have come about. In 2014, the Preventing Sex Trafficking and Strengthening Families Act was a real big catalyst that required states to develop policies and procedures to identify, document, and screen and service children through the Child Welfare Agency. In Nevada, prior to 2014, that was not occurring for all children in the state of Nevada and only was occurring for children that were in the foster care system at some level. So in 2014, the federal act came out and said we needed to start transitioning all children who fall within this category to the child welfare system. So where were we pre-2015 session? There were a lot of children that were identified by police for solicitation of prostitution, and they were arrested, detained, and charged and adjudicated for those offenses in the delinquency system. In Clark County, under Judge Voy, we were running a specialty court specific to that population of children that were being arrested and detained and charged. That specialty court had service providers that were there to help wrap the child into services. But at that time, we were still treating them as delinquents. And at that time, unless there was a parent or a person responsible for the welfare of the child, like a guardian or other person found in the home, the child welfare agencies were not the primary agency providing those services. And in 2015, there was a constant conversation around our need for safe houses in order to get the appropriate treatment and services for these children. So then the 2015 session came, and we had a bill, AB 153. It was our version in Nevada of a safe harbor law. So it ended up being codified as 62C 240. So at that time, a collaboration of community partners came together and determined we were ready as a state to ensure that we were not adjudicating, or for those who aren't familiar with that term, that would be familiar in criminal, would be finding guilty. We call it adjudication in juvenile, for solicitation of prostitution or for prostitution. So our version of the safe harbor law then would allow the district attorney's office to still file the charge. It allowed for the child to still be arrested and detained for the charge, but we were not able to formally adjudicate the child for the charge, so they were not found guilty of it. We were only allowed to supervise and provide services at that point, and only for those two acts. The court could still order out-of-home services and out-of-community placements in the best interest of the child. The court may still issue all orders for the compliance with recommended services, meaning he could still order a child, or he or she could still order the child, you have to do this, and if you don't do it, then your consequences could become greater. And then at 18, there was an automatic dismissal, so it was not on the juvenile record. At 18, if the child wasn't complete, or the young adult wasn't completed services, the young adult could agree to stay under court jurisdiction longer, but that again was up to that young adult who turned 18. And at the end of the 2015 session, there was still no funding for safe and appropriate housing for these victims. So then in the 2016 interim, the conversation that was sparked by AB 153 brought us to the Nevada Coalition to Prevent the Sexual Commercial Exploitation of Children, which, if you are okay with it now, I'm going to call it CSEC because that is a mouthful. And that was established by the State of Nevada Executive Order. So that takes us over to the 2019 session, where there were two significant pieces of legislation, AB 293 and AB 151. And these bills highlighted the movement toward implementation of the federal requirements that had child welfare agencies as the primary agencies that were identifying, screening, and servicing CSEC. SB 293 was again the product of collaboration and compromise to take steps in moving toward the creation of safe housing and safe harbors. So 293 created a contract position for a statewide coordinator. Interim meetings to assess were legislated in order to assess gaps in services, housing needs, and evaluate incentives needed to recruit providers of these safe houses that we are in need of. And at that time, SB 293 took safe harbor one more further step closer to a true safe harbor law, stating that anybody who had reasonable cause to believe a child is a CSEC is prohibited from arresting, detaining, and adjudicating the children for solicitation of prostitution, curfew jaywalking, loitering for the purposes of prostitution. I listed the violations of the statutes. And in 2019 session, that was to become effective in July of 2022. When we moved that effective date to July of 2022, it was because we still didn't have that housing option. So if we remove the housing option of detention, which is absolutely not appropriate for this population of victims, we still didn't have the buildup of what was truly needed within our state. AB 151, which is very special to me because it was one that I drafted out of my own brain concept. It created its first standalone statutory section to address the identification and needs of our CSEC. So we now have what is known and codified as NRS 432C, the protection of children from sexual exploitation. Over the past few years leading up to 2019, across the country, states were aggressively passing legislation to transition the identification and care coordination of CSEC to child welfare agencies. However, states were cramming those laws into traditional child abuse and neglect statutes that were really designed to identify and treat children that were abused and neglected by parents or guardians, not by traffickers. And in most CSEC cases, the parents are not the ones exploiting the child. So to cram into our child abuse and neglect statutes, people that are not persons responsible for a child's welfare through parent guardianship, it was a little odd, and also seemed to, in some cases, be punishing parents, even though they were not really involved in it. So we were successful in addressing the legislature and the LCB to create this standalone statute that you all now have to put anything you'd like to with regard to child victims of sex trafficking. So in this AB 151, it has mandated reporting requirements. So now anybody who is a mandated reporter of child abuse and neglect, if they have reasonable cause to believe that a child is a victim of commercial sexual exploitation, they are required to call in a report to the intake unit of the Child Welfare Agency. When that intake call is received, child welfare agencies will screen them, assess for risk, and assign for assessment if deemed necessary. And child welfare agencies are able to provide services directly, or they may refer out for service to service providers. It again does not require the parent to be the perpetrator of the sexual exploitation. It requires a cross report to law enforcement so we can hopefully identify the trafficker. And once again, there was no funding to support this new responsibility on child welfare agencies. But they are doing it, and I think we heard Administrator Birch mention that they have a caseload of about 398 children since the Child Welfare Agency has taken on this role in Clark County. So after the passing of those two pieces of legislation, we move into the interim of 2020. And at that time, the governor directed the Division of Child and Family Services to establish a statewide coalition. The focus of that coalition was to ensure, implement, and develop the recommendations for services and legislation and best practices. So in 2019, when we go back to SB 293, it started out as a very aggressive bill that mandated what type of housing we needed, mandated that housing lay in the responsibility of the Child Welfare Agency, and ultimately, with the stakeholders discussing it, it was determined we really needed to make sure we were building up the correct housing for these victims. And so this interim 2020, we started this statewide coalition that was discussing all of these needs involving housing, as well as services and potential legislation. So that coalition started 3 subcommittees: our local task force subcommittee, and multidisciplinary team subcommittee, external engagement, funding, data, and sustainability. So each of those, I have a little bit on each of those subcommittees. And so the local task force and MDT subcommittee coordinated the interagency approach to assessment, service planning, and case management. That is all in the best interest of our children if we are all working together at one table talking about the same child, so it's not in various silos re-traumatizing that victim, and making sure that we have smooth services entering for that child. That's what our local task force MDT group was looking at. External engagement was the review of our rapid indicator tool. That's our screening tool that's used statewide and by community partners, including juvenile justice services here in Clark County. We also, in external engagement, we're making recommended changes to Nevada 211 for more accessibility for survivors and families and providers. And funding, and that met a requirement found within last year, 2021 session, SB 143. Funding and sustainability, we developed a comprehensive statewide CSEC database. We're working now with UNLV partners and looking at other management information systems to connect with our CSEC case management systems. So now in our 2021 session, we have from that interim SB 274. It took the work from the 2020 interim. It recognized that we needed a continuum of care for our victims and survivors. It's not just we need one thing. There are different levels of trauma and treatment throughout this survivor's journey or victim's journey to survivor, and that we needed to make sure that we were implementing that continuum of care. One very significant piece that was determined to be within that continuum of a care was a creation of our creating the foundation for a receiving center. That receiving center is modeled after one that is in the state of Georgia operating fully right now. It would be a secured facility that operates 24/7 to provide appropriate inpatient and outpatient services. It is not a detention facility or a group foster home. It was to focus on complex trauma and the needs of our victims and survivors. It moves the implementation of SB 293, which I just talked about earlier, and this is a typo on my slide, so don't get all excited. We are not moving it in July 1st of 2022. It got kicked to July 1st of 2023, and that would be the no detainment, no adjudication section of SB 293. And once again, at the end of the 2021 session, we did not receive any funding toward any housing or toward staffing the needs of the child welfare agencies to screen and assess these victims for services. So now where do we need to go? I want to start this slide by saying that my last substantive slide, which is coming up, these legislative recommendations come from discussion among stakeholders on the statewide coalition. These recommendations were also presented to the Judiciary Interim Committee, and they are not vetted for fiscal impacts on agencies. Many of them come from recommendations of a Shared Hope report card, and for those of you who are not familiar with the Shared Hope report card, it's a national organization that looks at each state and grades it A through F on their response and treatment of child sex trafficking victims. So Nevada, I have it with me here. I know you can't see me because my PowerPoint's up, but you can if you're down south. We had an F for the 2021 report card. So the statewide coordinator, Esther Rodriguez Brown, and I reached out to Shared Hope International to talk to them about our F. And when we were concluded talking to them, going case line by line as to what we saw and some of the things that I think we really already do that they just misinterpreted, I think we moved up to a pretty solid D from the F because they did not understand our statutes. Again, this is a national organization and they're not, trained in understanding how we interpret our statutes. So I think we moved up to a D. That still isn't really great, right? And it actually, we've come a long way, I will say. We've come a really long way and definitely further than a D. If you look back at where we started to where we are going now with my presentation. And so I want to say this, we learned this after the fact, but Shared Hope changed the goal line. So there was a shared hope report card years ago, and all the states started getting A's and B's and moving up. So then they moved it out and said, okay, we can do better. And that's, you know, of course we can do better. We can always do better. So the goal line kind of moved. So we haven't been a flunky forever. We actually did really well, and now they've moved it, and now we need to progress. So some of the recommendations on my next slide are recommendations of the shared hope report card for legislative changes, and the stakeholders among these coalition groups have decided that they would like me to present these to you. So, possible legislation. Mandate the creation of multidisciplinary teams to collaborate and prevent additional trauma for our victims and survivors. We are actively working right now on the shell of that legislation within a legislative subcommittee. There are foundations within statute already for multidisciplinary teams around issues that impact our children and families within our statute. So that one we are hoping will be an easy fix to mandate that team. The second one is mandate that child welfare agencies and juvenile justice agencies screen children to see how they are experiencing commercial sexual exploitation. Right now in Clark County, we are already screening children that are coming into the system, either juvenile justice or child welfare. It is just not statutorily mandated that we do so. I am unfamiliar with what the rest of the state is currently doing. I know that we have talked about everybody in the state using the same screening tool, and hopefully that will be rolled out. The next one is to create stronger safe harbor statutes. There are so many versions of safe harbor statutes across the country. It would definitely be a policy decision among members to decide where they wanted to take the state of Nevada. Ensure the extension of foster care to cover young adults age 21 to age 21. In 2019 and in 2021, there were two bills that were addressing this very issue. I put them for reference for you there. I think we are moving in that direction. We just need a little more technical assistance, I think, in the state. Extend the ability to testify by alternative means to all victims under the age of 18. So a child who is a victim of sex trafficking right now, who is 16 or above, does not have the alternative to testify, the ability to testify by alternative means. It does not apply to them. So there's a recommendation that we do extend it to the 16 and above. And then two of our more controversial ones, I think, would be one, eliminate licensed houses of prostitution, and two, tougher penalties for buyers of a child. So that's my past, present, and hopeful future for you all, and I'm ready to take any questions you may have.
Thank you so much for the presentation. I have a question from Assemblywoman Gorlow. Please go ahead with your question.
Thank you, Chair Peters, and thank you for being here. I had received an email a couple weeks ago from somebody who was requesting that we add child sex trafficking to the state's statutory definition of child abuse and neglect under NRS 432B. But I also work with some people who had worked with the county and was talking a little bit to them and was stating that that would be a problem because that would require CPS people to work with pimps and potentially even family members that were the ones that were actually selling the child. So could you elaborate or explain to me a little bit more about that?
Yes, thank you for the question, Assemblywoman Gorlow. Bridget Duffy for the record. Actually, that is not too much of a difficult fix, I will say. So currently in the court improvement realm through the Nevada Supreme Court, we are working on legislation, and one of those pieces of legislation is actually to add to the definition of sexual exploitation within NRS 432B, commercial sexual exploitation. So that would then apply to parents, guardians, or persons responsible for a child's welfare who commercially sexually exploit a child, only to them. And sometimes parents are responsible for those things. So unfortunately, so sometimes they are. So it's not, it is something that we are missing within NRS 432B. It's something that was also brought out by Shared Hope. We do have sexual exploitation listed as a definition of child abuse in NRS 432B, but there are some who believe that that doesn't go as far enough to capture commercial sexual exploitation of a child. And it would only then apply to those parents who do it or guardians. We still have 432C where we can service and help children outside of a parent who is doing that exploitation.
Thank you very much. That confused me a little bit more, but we'll have more conversations.
Thank you for the question, Assemblywoman Gorlow. I think that that's would be an interesting bill draft potentially if we do see that it's necessary. I have another question up here from Dr. Titus. Please go ahead.
Thank you, Madam Chair. And Ms. Duffy, thank you for your presentation, your continual advocacy of the youth of Nevada. So much appreciated. I just have to kind of go back to your last statement on some ways to improve this. And you mentioned legalized prostitution. And so did you say eliminating legalized prostitution in Nevada as one of your goals or one of your solutions?
Bridget Duffy for the record. Thank you for the question, Assemblywoman Titus. So yes, it would be eliminating licensed houses of prostitution.
So it's my understanding.
And I know that's been a very difficult, yeah.
So I just want to focus on that for a little bit. As a county health officer in Lyon County, and a county who has legalized prostitution, and where I have been in and inspected the brothels here in our county, wondering what data you have that there is a expansion of childhood or in our legal brothels in the state of Nevada.
Again, thank you for the question, Assemblywoman Titus. Bridget Duffy for the record. So I'm gonna do my best. I wish I had my partners from up north with me from Awaken, because this has been a long conversation with them over the years. So one of the recommendations from Shared Hope included that elimination because of the message that it sends, because it's bleeding over into our illegal and starting with our children that are being trafficked in the streets and then bringing them up and then into the legal houses of prostitution, that if we can get rid of that stigma that it's okay at all to buy sex, then we would be assisting our children that are being picked up on the streets. And I really am not the best one to talk about the specific issues, as this is one that our advocates that we work with in the collaborations across the state. Although I do agree, and I agreed to put it in the slide as one of the bold recommendations that the group has coming forward.
Great, thank you. Because I would argue that perhaps in Clark County and Washoe County, you see it perhaps more, and I'm just concerned that by that broad statement to eliminate all, there may actually be an increase in illegal trafficking, and I just have some concerns. So there's much further dialogue that has to happen with that, and that statement just kind of caught me by surprise. So thank you for that. Thank you, Madam Chair.
Thank you for the question. I also was curious about the where that came from, and I'm glad for the explanation and some further conversations, it looks like, with folks up here on those information and data. Are there any other questions from folks in the committee on this issue? I don't see any. So thank you, Ms. Duffy. Appreciate you being here and for your presentation. I believe our next presentation is, or our next agenda item is agenda item 9. Yeah? Okay. The intersection between homelessness and commercially sexually exploited children. We have some folks from Rite of Passage. They're not up here, so I assume that they're either online or in Las Vegas. But please introduce yourself and proceed when you're ready.
Hello, can you guys hear me? Okay, I see. Let me get my share screen going. I had some technical difficulties for a second. Can you see my presentation?
We can see the slides in the north. Are there? Can you guys see them in the south and on the virtual screens?
We can
Okay,
see them in Las Vegas, Chair. Thank you.
Looks good. Thank you so much.
It should be going now. Okay, well, thank you very much for inviting us to testify today and participate in this. We're going to talk about the intersection between homelessness and commercially sexually exploited children. My name is Lawrence Howell, for the record. I'm the Chief Administrative Officer for Rite of Passage. The Rite of Passage is a long-standing Nevada nonprofit that's been working with kids for over 35 years. We provide shelter, outpatient foster care, and residential treatment to teenage youth that are victims of commercial sexual exploitation. We currently have programs specifically for this population in Nevada, Hawaii, California, Utah, and Arizona. And I do want to say that everybody that has come before us today, I'm humbled by everybody who came before us today and spoke on this issue and other issues. We consider them partners, and we collaborate with every single one of them, from DCFS to Clark County, members of the committees and the commissions. We sit on those committees and those commissions with them, and it's clear we are one part of a very, very big issue, and we're just happy to be here and happy to answer any questions that you may have. I'm just going to do the introduction and hand it over to our director of our Las Vegas program to present a few things and then answer questions for you guys. So in Las Vegas, we serve youth CSEC victims in a shelter and in an outpatient environment and drop-in center. That was discussed earlier today about how drop-in centers are effective. And we do have a safe house. And there was lots of discussions earlier about funding and why there's not more of these services in Nevada. We applied for and received a Department of Justice Office of Victims grant to open the house. We have a safe house for 6 youth in Clark County, but we went to DC for the funding, and we're the only youth program in the state of Nevada selected to receive funding for that. And the facility opened up about a year ago and is going really, really well. So I think that Micaiah will speak more about that also. So we're going to transition now to Micaiah Swain, who is the director of the Embracing Project. And the Embracing Project is our Las Vegas hub of services for homeless and sexually exploited youth. She is the director of the program. She's a longtime advocate on the streets, in the community with the kids, really fighting for sexually exploited youth and homeless youth, and everything that we're talking about today. So with that, I will hand it over to Micaiah, and I will drive the slides as she directs.
Thank you, Lawrence. Can everyone hear me okay?
We can, thank you.
For the record, my name is Micaiah Swain. I am the director of the Embracing Project here in Las Vegas. Just a little bit of an overview of some of the services, and then we'll get into the topic at hand. We do offer wraparound trauma-informed services for youth victims and survivors of interpersonal violence, not just sex trafficking, also sexual assault, molestation, domestic violence, and any other interpersonal violence that kids may have experienced. We have 3 sides to our program. We have our sexually exploited youth program, which is focused on the sexual exploitation of children. We have our mentoring program, which functions more as a prevention program, focusing on connecting teens, any kids between 12 and 18 with either individual mentoring or group mentoring. And then we have, as Lawrence mentioned, our housing program for 6 youth that is CSEC specific. We focus a lot on court advocacy, court accompaniment when kids are going to testify, individual advocacy in the community. I'm sure, as you can imagine, children who have been exploited do have difficulty advocating for themselves and the needs that they have, and also being taken seriously by adults around them because of their age and some of the things in their history. In our drop-in center, we are central to Las Vegas. We're in the downtown area. We picked this location on purposefully because before before we had our first drop-in center, youth were traveling all around Clark County to receive services. They would receive some things in North Las Vegas, some things in the east, some things in the middle, and they were getting around primarily on the bus as they lack supportive adult figures in their life that will help them with transportation. So our drop-in center is central. We offer individual therapy, group therapy, family therapy. We do a lot of family support because it is a total family issue. And then in order for us to have the best outcomes, we do need to identify support systems. That might be blood-related family, or that might be their chosen family, to make sure that once they do exit our program, once they are finished with services here, they have people around them who are going to support them in the needs that they have. We have a CCSD approved school here. We operate through the adult education program, which has been absolutely fantastic. You'll see that a lot of the services that we provide to kids were born out of need. Originally, we did just start with BSD and PSR services, but as we got more and more kids in the program, we noticed more and more needs coming up. So as the needs grew and as we were struggling to find other service providers to fulfill those needs, we expanded our programming and adjusted to meet the needs of the kids that we work with. And I will say kids a lot, but they are 12 to 21, so, big kids, but I will refer to them as kids. We have, like I said, we have our school here. What we were noticing, one, was that we had a lot of the kids in the program were at our drop-in center during the day when they were supposed to be in school. And so we addressed the issue with them and asked them what was going on in school. And they were just having a lot of trouble functioning in a traditional school environment. A lot of the kids we work with have mental health issues, PTSD, they have a lot of triggers. And as you can imagine, putting all those things together in one child does not necessarily make the ideal student. They were struggling. Some of the kids were still on the streets. Some of the kids were still under the hands of their traffickers. So they would sleep in class, get in trouble. Things would happen in school. There was fighting. And they really lacked the resources, internal resources and external resources to be successful in a traditional school. So we brought the school into our program, and we've seen at the moment, we've seen about 25 kids graduate through our school. We should have some more graduates this year as well, which will be fantastic. And it's a really great environment for them to be in, because they can attend school, but if they need a break, if they need a nap, if they're having a bad day and they need to cry, they can do that. And we have great teachers here. We're always assigned special education teachers. For the most part, the majority of the kids we work with would qualify for an IEP. However, they're not in school long enough to actually get assessed for an IEP. So that the school's been fantastic. We actually have school today, so it might get a little bit loud behind me. We also have, of course, basic necessities: clothing, hygiene, food, things that kids need just to survive. Because if we can provide them here, it saves them from having to go out and look elsewhere for those basic necessities. And at the end of the day, when we're speaking about kids from families that don't have extensive resources when it comes to things like hygiene products and clothing and school supplies, when we're given the choice to provide a roof over our heads and food, or get things like hygiene items and clothing and school supplies, we're going to choose the things like shelter and food. So we do have those basic needs here. We also do a lot of job readiness, whether that's resume building, interview skills. We're really teaching and helping to educate kids on how they can function in a world that is jobs and working in establishments and businesses and working, filing taxes, all of those things that come they're not necessarily taught in school. They're certainly not taught those things on the streets. So it's transitioning kids from where they were before and how they think about money and working and things like that into okay, let's look at careers and things that you can do and get you qualified for jobs here in Vegas or elsewhere if they choose to move. We do a lot of life skills education. That's working on communication skills, social skills, identifying. We do have to do a lot of work on identifying toxic or violent relationships or relationships that are very unhealthy. For the most part, many of the kids we work with, and I will, with this caveat, in 2020 we did serve 121 sexually exploited youth. So at the time of their intake, which is their first day, we take them through a comprehensive intake and ask them about their lives. So at that time, 49% of those kids did identify as either having witnessed or experienced domestic violence. In addition to that, another quarter of the kids had experienced dating violence in their intimate relationships outside of the relationship with the trafficker. So when we speak about kids who are surrounded by violence or violent families or just chaotic families and relationships, they have a lot of difficulty identifying what a healthy relationship is. And that's not just within the family unit or within dating relationships, it's also within support systems. So it can be uncomfortable sometimes for kids when they first start the program, because we are a building full of very supportive adults who are looking for, healthy relationships with the clients that we work with. So when we're modeling those behaviors, it is a very unfamiliar thing that can create a little bit of uncomfort within the kids, because it's really learning something new for the very first time. Of course, we do a lot of mentoring, modeling pro-social behaviors. We do have kids who bring their kids here, so we assist them with that, making sure we're getting them connected with the proper parent education. And just really, if there is a need that one of the kids has here, if we cannot fulfill it, we reach out to our partners. We have fantastic partners. We partner with Signs of Hope, formerly the Rape Crisis Center, Family and Child Treatment of Southern Nevada. We have an extensive range of partners that really we've all come together to support kids as best as we can. We do also, as I mentioned, we do work with the whole family. So we have a parent support group for parents who have sexually exploited children. So we do have a parent support group, and we also do parent education. And to connect between homelessness and sexual exploitation, as I've given you a little bit of the picture that we work with, the kids that we work with, 79% of the kids that we worked with in 2020 at the time of their intake identified that they had run away at least once, and that was only at least once, and that was ranging from 3 days to we had one young lady who had been a runaway for 2 years, and she had actually lived in California in the tent city, and that's where she'd lived for 2 years at the age of 15. So when we talk about runaway, it's unsafe for children to be on the streets looking for shelter, and that's when a lot of sexual exploitation can occur. One of the very underreported forms of sexual exploitation is youth who are engaging in survival sex. Survival sex meaning exchanging sex for anything that is a basic necessity. So they are, food, a place to stay, those are basic necessities that every child should have. When they don't have them and adults around them notice that they do not have them, they can fall into exploitive relationships where they are exchanging sex for those basic necessities. Survival sex is not always classified as trafficking. However, survival sex can progress into a trafficking situation, just because there is, as you can see here, it is basic necessities. These are the things that they need to have to survive. So there's that. It creates a very large imbalance of power. As I said, not always considered CSEC, and it is a very, very underreported. Already trafficking itself is very underreported because some victims and survivors do have difficulty identifying themselves as being victimized, but also have difficulty reaching out and letting other people know that things are happening to them that could be considered victimization, because there is still a lot of stigma, a lot of shame, and a lot of victim blaming with trafficking. Despite all the education, despite the documentaries, despite all these things that we as a community and the public have access to, there is still a lot of shame, shaming of victims, which creates a situation where they may not feel safe or like they can trust anyone to report the crimes that are occurring. And it also, trafficking in general encompasses a lot of different issues. There is domestic violence. We do see teen pregnancy, which then creates another basic necessity, because now they're not only trying to provide for themselves, but for their children. We do see substance abuse, gang activity. All of these things are happening in one child at one time. And again, as I said, mental health issues as well. So if you can imagine putting all of these issues into one child, the push and pull factors for trafficking are just tremendous. A lot of our objectives here, as I said, our programs were born out of need. So when we established the Safe House for CSEC children, it was born out of need. We had youth here in our program who were maybe being kicked out, maybe running away from a situation where there was violence in the home. We had in 2020, we had about 60% of the kids identified as experiencing sexual assault or molestation, either in the home or on the streets. These are the situations they're trying to get away from. And sometimes these are the situations that they end up back in when they do not have safe shelter. So when we created that house, it was to an extension of the programming that was already working for the kids. It was to surround them with comfort, to help make them feel safe, to let them know that it was okay to be in their own individual selves, and to be accepted by people in the community, and to let them know there is still a really big place for you in our community. So we did create that house. Right now we have 4 young ladies in the house. We have had a total, I'm estimating here, but we have had a total of 11 kids go through the house, many of whom who have transitioned over into their own independent living situation, whether that's in an apartment of their own or they've transitioned into a more permanent housing program. We do also work with Nevada Partnership for Homeless Youth and Southern Nevada. It's escaping me now, but we do work with a lot of the homeless youth programs here, because again, we have a program of 6 beds. 6 beds is not enough. And when you hear Bridget talk about funding and things like that, the funding is not there and it is needed. We have right now 4 kids in there. We've identified many more who need housing, and we have children who are currently receiving services from us who are in Child Haven, who are in the homeless youth shelters. We have young adults who are currently in the adult shelters. So there is a very large need for this. So that is one of our objectives, is to increase our capacity for providing that safe and stable transitional housing for children. And of course, our goal and our objective is to provide services that meet the individual needs of the youth. We do have some of our services up here, and everything that we do is tailored to the individual. Although we have kids who might have been in similar situations, and even children who might have been exploited by the same person, their needs are very, very different, and it does require us to adapt to each individual, and that is the care that they deserve. So as I said, we have individual, group, and family therapy. We have 4 therapists at the moment who are all very, very well versed in trauma, but also the issues of CSEC, substance abuse, domestic violence, and a host of other issues as well. We do a lot of crisis intervention. As I spoke about before, kind of the profile of the kids that we work with, there is a lot of crisis situations that come up. They do not have a lot of coping skills as we think about them in the traditional sense. They do have a very high threshold, unfortunately, for suffering, as at the hands of adults usually, and for violence, but they do not have a lot of coping skills to deal with a lot of the issues that come up in regular teen life. That is relationships, that is disagreements with parents. A lot of these regular type issues, they do not have the coping skills or de-escalation skills to deal with those issues. So we do a lot of crisis intervention, not only with the kids, but we also partner with Signs of Hope to man or lady, if you will, the 24/7 human trafficking hotline, the alert hotline here, which is an in-person response to identified victims of human trafficking. So we do partner with them to operate that hotline. Again, this is crisis intervention. We're interacting with victims and survivors on what could be possibly one of the worst nights of their life. It does take a lot of de-escalation and a lot of just being with them in the moment. And of course, the follow-up that comes from that as well. As I said, we have a school program here. We do need, obviously, right now we are doing 2 days a week, which is working for a lot of the kids, but we will eventually need to expand that to more availability. We will need some more nights. We'll need early mornings because we are working with teens who have kids, have jobs, have other responsibilities, and they do need that expansion of that school program. Material resources, anything that kids might need that are basic necessities, we try to have on hand here at our drop-in center. Everything that we have that is material is donated. We have some great partners in the community, just really kind individuals that see the need of the kids that we have and donate as much as they can to us. So they've been absolutely fantastic. Our Girl Circle program is part of our prevention program. So that is our group mentoring for kids who are just starting to get into trouble, starting to become system involved, or people are noticing that they're having difficulties. In powering classes, we adapt to the time. So we create a lot of classes, like I said, around healthy relationships, budgeting, managing money, also around kind of what money means to the kids we work with. We do a lot of classes around that. Photography classes, we're really trying to find things that bring the kids joy. Unfortunately, a lot of the kids we work with, when we ask them, what are some things that you enjoy doing? They don't have a lot of things that they enjoy doing. They don't have a lot of regular teen experiences when we talk about hobbies and sports and things like that. So we try to introduce them to as many things as possible. They definitely don't like every one of them, but it gives them an opportunity to see some different things. And if they find something that they like, sometimes it's odd things for teens. We have one girl who really likes to crochet that she didn't know how to crochet. But we do try to introduce them to as many positive activities as possible. And then that employment support, I'm sure, as you can imagine, children who don't have extensive resources and don't come from families with significant resources, they are looking for jobs at 15 and 16 and getting into the workforce. So we do support them in that. We do a lot of resume building, practicing interview skills, going with them down. So they, standing on the outside of the store while they go inside to ask for the hiring manager. Just a lot of support in that way, and then helping them with clothing once they do find a job, helping them with their taxes. As I said, everything that we have here was born out of the need and what the kids were requesting and what the needs that they had. So that is what we do. And yes, that is us. If anyone has any questions, please let me know. Or if Laura has anything to add.
Yeah, I just wanted to, can you guys hear me? Okay. The best example I can give on where homelessness, youth homelessness and CSEC, those issues collide was last year we had a young lady who was constantly asking for bus passes, which we provided the Embracing Project. And when we finally dug into why she needed a bus pass, because she was being exploited, she did not feel safe in shelters that were offered to her. So she was sleeping on the bus at night. And so she would get on the bus, she would tell the bus driver, I'll be in the back, I'm going to go to sleep. The bus drivers had an agreement to just leave her alone. And it was so sad and so disheartening when we found out about that. She was surviving. She was doing whatever she could to survive because she had no place to live. She was homeless. And so once we found that out, we connected her with other community resources that were safe. And that really got us motivated to get the Safe House started for situations like that, where you discover something today and you need to deal with something tonight. And so now we have that house. It's called Canyon View Shelter, and Canyon View is there for that type of situation while we work on something more permanent. So with that being said, thank you very much. Like I said before, we partner and collaborate with just about everybody who has spoken today and who is going to speak. It's a big, big issue, and we're very proud to be part of this group that's doing something about it. So with that, Makai and I will answer any questions. Thank you very much.
Thank you for the presentation. I have a quick question. How many nights on average do you have a person in your safe house during one stay? What's the average stay look like there? Because you said it's 6 beds, right?
Right. It's 6 beds. It really varies depending on the needs of the child. We've had one young lady's been there for 5 months, and we have some kids that are there for 5 days, and we had one that was there less than 5 hours. So it really just depends on the needs of that individual kid.
Wow. Okay. Are there any questions from the committee on this issue? I'm not seeing Vegas, so if you have a question, please pop on your microphone and say me. Well, really interesting program. It sounds like what your big look to the future is to expand and be able to offer more beds and maybe more community partnerships to ensure that we have places for long-term places for those kids to go. If you come up with a way that we can help you with that, please let us know if there are other things that we can do to help. Oh, excuse me, Assemblywoman Titus has a question.
Thank you. Quick question on rite of passage. And so rite of passage has been in my community and for decades, literally, in Mason Valley, which I represent that area. So just curious, are you still going to continue the school that you have there in Mason Valley?
We actually have 26 sexually exploited youth girls in that program right now under a Nevada PRTF license because there was no real place to put it. And so last year we got it licensed as a PRTF, psychological residential treatment facility. And the girls there are, we're really trying to build a continuum. So we have the drop-in center, and then we have the safe house, and now we have a PRTF for the girls that are really traumatized, really need intensive therapy. That place is very effective as remote in the Mason Valley there. And, with 30 or less girls there, we can really provide a lot of intensive services and then hopefully transition them back to the community through the drop-in center or to a whole new community depending on their individual needs.
And thank you for that. And so in the past, you've taken students from El Dorado County and California areas. Are you still doing that, or are all these all Nevada people?
They're not. They're mostly Nevada girls right now. But like we have a program for sexually exploited youth in Hawaii, and we have one in Los Angeles County area. And sometimes the victims need to get out of where they're at to get away from the people that are exploiting them. So we actually have 2 girls from Hawaii in Yerington, and there's a couple of California girls that we sent to Hawaii to really create some distance between them and the situation while we work on the trauma and work on their individual needs before we decide where they're going to go back to. So it's mostly Nevada girls right now, but there are some girls there from other places based on they need to not be where they came from for a little while.
And last question, if I might. So in the one in Mason Valley, you said you have 26 gals there now, and what's your capacity?
It's licensed for 50, but we're very, very selective in who we take and the services that they need. So right now we have a waiting list of youth that need to get in, and but we're at 26 because right now that's what the milieu can safely handle. And
what's your waiting list numbers?
I didn't look this morning, but yesterday it was about 8 girls.
Okay. All right. Thank you. Thank you for the questions. Thank you for what you're doing.
Yes. Thank you.
Thank you for the question. Are there any other questions on this particular item before we move on to the next agenda item? I do not see any, so we will go ahead and move on to our next agenda item. Thank you again so much for being here today and for your work in Nevada. Appreciate you.
Thank you.
Our next agenda item is agenda item 10, a presentation on foster care services for children with severe behavioral, emotional, and medical disorders. I have Lori Jackson on my list who will be presenting. Please introduce yourself and proceed when you're ready.
Lori Jackson, Social Services Manager for Rural Child Welfare. Thank you. I'm going to talk a little bit about specialized or treatment foster care, and it's a very quick overview of what those services are. As you can see, we're going to talk a little bit about what a higher level of care is, the criteria for that, the training, and then the challenges. Specialized foster care can also be known as treatment foster care. Specialized foster care or advanced foster care is the rural child welfare's version of specialized foster care. It is a treatment system that is designed to provide behavioral supports to children who have not been able to maintain in regular home foster care or within relative placements. They have mental health or behavioral needs. These homes are the stepping stone before we would be looking at residential treatment or psychiatric treatment facilities. We use a system of care approach in these specialized foster homes with specialized training. The specialized training in Together Facing the Challenge, which is a specific program that Duke and Penn universities were able to develop. And I'm sorry, slide. Whoever's working the slides. I think you can go one more. Thank you. So the criteria for admission into a specialized foster home, there is criteria that needs to happen before a child is simply placed in a more restrictive setting. They have to have a comprehensive biopsychosocial assessment. They need to have a severe emotional disturbance designation. They have had to have failed prior less restrictive placements, whether that was family, kin, or family foster care placements. And they have to have a CASI score. CASI is a Child and Adolescent Services Intensity instrument of 18 or higher. Specialized foster care and the staff in specialized foster care are provided the Together Facing the Challenge training that these homes have. This training is geared toward the foster care provider. It has an ancillary benefit to the child because that foster care provider has a coach that they work with that is a supportive and involved relationship between that coach and that foster parent. It uses effective behavior management strategies, and it's a supportive and involved relationship between foster parents and youth in their care. We have found that it limits or it helps stop youth from disrupting in those homes and then having to look at a higher level of care, more restrictive, which may be residential treatment either in-state or out of state. The total youth enrolled currently, the snapshot that I have, as you can see, Clark has the majority of those children simply because of their population. Rural has about 31 children that fall into that designation. The challenges and strategies, I won't go over again. I went over them in the last presentation. I think you've heard it about 3 times now. Specialized foster homes were a little more immune than family foster homes at loss. We didn't lose as many of them, but we don't have enough to begin with. So the behavioral issues that we were seeing coming out of the pandemic, in my first presentation, I talked a little bit about there were less calls, but those calls were much more severe, and there was much more trauma involved. These children are coming into care and requiring these specialized homes. And like everything else, there's not enough of them. So we are working to try to do some dual licensing in the actuarial study that we're looking forward to. And we do consult regularly with our agency homes that reside mostly in our urban areas to see about opening homes in rural child welfare in some of our more rural areas. I'm open for questions should the committee have any.
Thank you so much. Are there any questions from the committee on the brief presentation on this issue? All I see is Senator Doñate, so if you're in Clark County, please go ahead and unmute yourself. I'm not hearing any questions today on this. Thank you so much for being here. Really appreciate what you do. and your program for these kids.
Thank you, Madam Chairwoman, and the committee members.
Great. That is a good place for us to break for lunch, I believe. There is lunch in Clark County and here as well, and we can discuss which room it is. We're going to do 30-minute lunch. We're going to do a 30-minute lunch since food is in the building. Sorry for those who are virtual. I hope you brought lunch to work. But we will go ahead and recess and be back here at like 1:15. Thank you so much.